Welcome to this video entitled, Pharmacology of Adrenal Disorders and Corticosteroids. Welcome to this comprehensive overview of the pharmacology of adrenal disorders and corticosteroids. The adrenal cortex is a highly specialized endocrine factory responsible for synthesizing hormones that are absolutely vital for survival. Among these, the glucocorticoids stand out as some of the most frequently prescribed, highly effective, yet extensively toxic medications in modern medicine. They represent a pharmacological double-edged sword. They are unparalleled in their ability to rapidly suppress severe inflammation and immune responses, making them life-saving in acute crises such as status asthmaticus or anaphylaxis. However, their pervasive genomic mechanisms mean that their prolonged use inevitably leads to multisystemic toxicity. In this presentation, we will dissect the normal physiology of the hypothalamic-Pituitary-Adrenal axis, decode the precise molecular mechanisms by which synthetic corticosteroids exert their effects, and evaluate the nuanced pharmacokinetic properties, like CYP3A4 metabolism and 11-beta-HSD enzyme interactions, that dictate clinical decision-making. The adrenal cortex is the outer part of the adrenal gland and plays a vital role in maintaining normal body function. It produces several important hormones, including cortisol, aldosterone, and adrenal androgens. These hormones help regulate metabolism, blood pressure, immune responses, and the body's reaction to stress. Sitting above each kidney, the adrenal glands may be small, but their influence on overall health is enormous. The activity of the adrenal cortex is controlled by the hypothalamic-Pituitary-Adrenal axis, commonly known as the HPA axis. This system acts like a communication network between the brain and the adrenal glands. When the body experiences stress, the hypothalamus releases corticotropin-releasing hormone. This stimulates the pituitary gland to produce adrenocorticotropic hormone, or ACTH. Adrenocorticotropic hormone then travels through the bloodstream to the adrenal cortex, where it triggers the release of cortisol. As cortisol levels rise, they signal the brain to reduce further hormone release, creating a negative feedback loop that keeps hormone levels balanced. Corticosteroids exert their effects through both genomic and non-genomic mechanisms. The genomic mechanism is slower but longer lasting. After entering the cell, corticosteroids bind to intracellular glucocorticoid receptors. The drug receptor complex then moves into the nucleus and influences gene expression. One pathway, known as transactivation, increases the production of anti-inflammatory proteins that help control inflammation. Another pathway, called transrepression, suppresses the expression of genes responsible for producing inflammatory mediators. Together, these actions account for many of the therapeutic benefits of corticosteroids. In contrast, non-genomic mechanisms occur much more rapidly. These effects do not depend on changes in gene transcription. Instead, corticosteroids interact with cell membranes, membrane-bound receptors, and intracellular signaling pathways. This allows them to produce quick responses, particularly during acute inflammatory or immune reactions. Understanding the pharmacokinetics of corticosteroids is also essential. Most corticosteroids are well absorbed after oral administration, although absorption can vary depending on the specific formulation. Once in the bloodstream, they are widely distributed throughout the body and often bind to plasma proteins such as corticosteroid-binding globulin and albumin. Only the unbound fraction is pharmacologically active and capable of entering target tissues. The liver is the primary site of corticosteroid metabolism. A key enzyme involved in this process is cytochrome P453A4, commonly referred to as CYP3A4. This enzyme converts corticosteroids into metabolites that can be eliminated from the body. Because many other medications also affect CYP3A4 activity, significant drug interactions may occur. Drugs that inhibit CYP3A4 can increase corticosteroid concentrations and the risk of adverse effects, while enzyme inducers can reduce corticosteroid levels and decrease therapeutic efficacy. Understanding these metabolic pathways is crucial for optimizing treatment outcomes and ensuring patient safety. One fascinating aspect of corticosteroid pharmacology is the role of the enzyme 11-beta-hydroxysteroid dehydrogenase, often abbreviated as 11-beta-HSD. This enzyme acts like a biological switch that controls the activation and inactivation of glucocorticoids within tissues. Two main forms exist. 11-beta-HSD1 converts inactive cortisone into active cortisol, increasing glucocorticoid activity in tissues such as the liver and adipose tissue. In contrast, 11-beta-HSD2 converts active cortisol into inactive cortisone, particularly in the kidneys, where it protects mineralocorticoid receptors from excessive stimulation. This enzymatic system is especially important for corticosteroid prodrugs. Some medications are administered in inactive forms and require enzymatic conversion before they can produce therapeutic effects. Synthetic corticosteroids can be classified according to their biological half-lives. Short-acting corticosteroids, such as hydrocortisone, generally have a duration of action of less than 12 hours. Intermediate acting agents, including prednisone, prednisolone, and methylprednisolone, typically act for 12 to 36 hours. Long-acting corticosteroids, such as dexamethasone and betamethasone, may remain active for more than 36 hours. These drugs also differ significantly in potency. Hydrocortisone serves as the reference standard, while prednisolone is several times more potent. Dexamethasone is considerably more powerful, producing strong anti-inflammatory effects at much lower doses. Understanding these differences helps clinicians choose the most appropriate drug for each clinical situation. Although corticosteroids are highly effective medications, they are associated with numerous adverse effects. Short-term therapy may cause increased appetite, weight gain, mood changes, insomnia, fluid retention, elevated blood pressure, and increased blood glucose levels. Some patients may also experience anxiety, irritability, or gastrointestinal discomfort. These effects often appear within days or weeks of treatment initiation. Long-term corticosteroid use carries more serious risks. Chronic exposure can lead to osteoporosis, muscle wasting, skin thinning, easy bruising, delayed wound healing, cataracts, glaucoma, and increased susceptibility to infections. Patients may also develop characteristic features of Cushingoid appearance, including central obesity, moon facies, and fat deposition over the upper back. These complications highlight the importance of using the lowest effective dose for the shortest possible duration. A major concern during prolonged corticosteroid therapy is suppression of the hypothalamic-Pituitary-Adrenal, or HPA, axis. When external corticosteroids are administered for extended periods, the body senses high glucocorticoid levels and reduces the production of corticotropin-releasing hormone and adrenocorticotropic hormone. Over time, the adrenal cortex becomes less active and may even undergo atrophy. If corticosteroids are stopped abruptly, the suppressed adrenal glands may be unable to produce adequate cortisol. This can result in adrenal insufficiency, characterized by fatigue, weakness, hypotension, nausea, and potentially life-threatening adrenal crisis. For this reason, corticosteroids should often be tapered gradually rather than discontinued suddenly. Tapering allows the hypothalamic-pituitary-adrenal axis time to recover and resume normal cortisol production. Safe tapering protocols reduce the risk of adrenal insufficiency while maintaining disease control and protecting patient safety. The adrenal cortex is a remarkable endocrine organ that plays a central role in maintaining homeostasis. Located in the outer region of the adrenal glands, which sit on top of the kidneys, the adrenal cortex produces hormones that regulate blood pressure, metabolism, stress responses, and reproductive functions. Although small in size, these glands are essential for survival and adaptation to changing physiological demands. The adrenal cortex is divided into 3 distinct layers, each responsible for producing specific hormones. The outermost layer, known as the zona glomerulosa, synthesizes mineralocorticoids, primarily aldosterone. Aldosterone helps regulate sodium and potassium balance and plays a critical role in maintaining blood volume and blood pressure. By controlling the retention of sodium and water in the kidneys, this hormone ensures adequate circulation throughout the body. Beneath the zona glomerulosa lies the zona fasciculata, the largest layer of the adrenal cortex. This region produces glucocorticoids, mainly cortisol. Cortisol is often referred to as the body's stress hormone because it helps the body respond to physical and emotional stress. It also regulates glucose metabolism, suppresses excessive inflammation, and influences immune function. Cortisol levels naturally fluctuate throughout the day, typically peaking in the early morning and declining at night. The innermost layer of the adrenal cortex is the zona reticularis. This layer produces adrenal androgens, including dihydroepiandrosterone and androstenedione. Although weaker than testosterone, these hormones contribute to the development of secondary sexual characteristics and serve as precursors for more potent sex hormones. The activity of the adrenal cortex is tightly regulated by the hypothalamic-pituitary-adrenal axis, commonly called the HPA axis. This sophisticated communication network links the brain to the adrenal glands and ensures that hormone production matches the body's needs. The process begins in the hypothalamus, a small but vital region of the brain. In response to stress, illness, or circadian signals, the hypothalamus releases corticotropin-releasing hormone, or CRH. This hormone travels to the anterior pituitary gland and stimulates further hormonal activity. Within the anterior pituitary, a larger precursor molecule called pro-opiomelanocortin, or POMC, is cleaved into several biologically active peptides. One of the most important products is adrenocorticotropic hormone, commonly known as ACTH. Adrenocorticotropic hormone enters the bloodstream and travels directly to the adrenal cortex, where it stimulates the synthesis and release of cortisol from the zona fasciculata. As cortisol levels rise in the circulation, a highly efficient negative feedback mechanism comes into play. Elevated cortisol signals both the hypothalamus and anterior pituitary to reduce the release of corticotropin-releasing hormone and adrenocorticotropic hormone. This feedback loop prevents excessive cortisol production and helps maintain hormonal balance. Through this carefully coordinated system, the body can respond effectively to stress while preserving physiological stability and overall health. Cortisol is one of the most important hormones produced by the adrenal cortex. It plays a vital role in helping the body maintain energy balance, regulate metabolism, control inflammation, and respond to physical and emotional stress. Although cortisol is often called the stress hormone, it is constantly produced even when the body is at rest. In fact, normal cortisol secretion is essential for everyday health and survival. Under normal physiological conditions, the adrenal glands produce approximately 10 to 20 milligrams of cortisol each day. This baseline production supports many routine functions. Cortisol helps maintain blood glucose levels between meals, promotes the metabolism of carbohydrates, proteins, and fats, and ensures that vital organs receive a steady supply of energy. It also helps regulate blood pressure and contributes to normal immune system function. One of the most fascinating features of cortisol is its circadian rhythm. Cortisol secretion follows a predictable 24-hour cycle that is closely linked to the body's internal biological clock. Levels begin to rise during the early hours of the morning, even before a person wakes up. This prepares the body for the demands of the upcoming day. Peak cortisol concentrations typically occur between 6 a.m. and 8 a.m. This morning surge promotes alertness, increases energy availability, and helps individuals transition from sleep to wakefulness. Many people experience their highest levels of concentration and physical readiness during this period, partly because of cortisol's physiological effects. As the day progresses, cortisol levels gradually decline. The hormone continues to support normal metabolic activities, but in progressively smaller amounts. By late evening, cortisol secretion reaches its lowest point. The nadir usually occurs around midnight, when the body is preparing for rest and recovery. These low nighttime levels are important because they help facilitate sleep and allow other restorative hormonal processes to occur. Disruption of this normal cortisol rhythm can have significant consequences. Sleep deprivation, shift work, chronic stress, and certain medical conditions can alter cortisol secretion patterns. When the circadian rhythm becomes disturbed, individuals may experience fatigue, impaired concentration, mood changes, and metabolic disturbances. While baseline cortisol production is relatively modest, the body has an impressive ability to increase hormone secretion during times of stress. In response to major trauma, severe infection, extensive burns, surgery, or other critical illnesses, activation of the hypothalamic-Pituitary-Adrenal axis dramatically increases cortisol production. Under these circumstances, daily cortisol secretion can rise from the normal 10 to 20 milligrams to as much as 100 to 300 milligrams per day. This stress-induced surge is a crucial survival mechanism. Increased cortisol helps maintain blood pressure, supports cardiovascular function, mobilizes energy reserves, and modulates inflammatory responses. These adaptations enable the body to cope with severe physiological challenges and improve the chances of recovery. In essence, cortisol is much more than a stress hormone. It is a carefully regulated hormone that follows a daily rhythm, supports normal body function, and provides a powerful protective response during periods of intense physical stress. Glucocorticoids are among the most widely used drugs in medicine. They are powerful hormones that regulate metabolism, suppress inflammation, and modulate immune responses. These compounds can be divided into two major groups: natural, or endogenous, glucocorticoids produced by the body, and synthetic glucocorticoids developed in the laboratory to enhance therapeutic benefits. The principal endogenous glucocorticoid is cortisol, also known as hydrocortisone when used as a medication. Cortisol is synthesized in the zona fasciculata of the adrenal cortex from cholesterol. Chemically, It is a 21-carbon steroid molecule that serves as the body's primary stress hormone. Under normal conditions, cortisol helps regulate blood glucose levels, maintain cardiovascular function, influence protein and fat metabolism, and control inflammatory processes. Although natural cortisol is highly effective, its pharmacological properties are not always ideal for clinical use. It has a relatively short duration of action and possesses both glucocorticoid and mineralocorticoid activity. For this reason, scientists developed synthetic corticosteroids by modifying the basic steroid nucleus of the cortisol molecule. Small structural changes can dramatically alter a drug's potency and duration of action. One common modification is the introduction of a double bond between carbon atoms 1 and 2, known as the C1-C2 double bond. This change increases glucocorticoid activity while reducing mineralocorticoid effects. Prednisolone and prednisone are classic examples of drugs containing this modification. Another important structural alteration is fluorination at carbon 9. Often referred to as C9 fluorination. The addition of a fluorine atom significantly enhances receptor binding and biological activity. Drugs such as dexamethasone and betamethasone owe much of their remarkable potency to these carefully designed molecular modifications. The development of synthetic glucocorticoids was guided by several important therapeutic goals. One objective was to increase biological half-life. A longer half-life allows the drug to remain active in the body for extended periods, reducing the frequency of dosing and improving patient convenience. Long-acting agents can provide sustained anti-inflammatory effects with fewer administrations. A second goal was to maximize glucocorticoid potency. Enhanced potency means that smaller doses can produce powerful anti-inflammatory and immunosuppressive effects. This is particularly valuable in conditions such as asthma, autoimmune diseases, allergic disorders, and inflammatory conditions where strong suppression of inflammation is required. A third and equally important goal was to minimize or eliminate mineralocorticoid activity. Mineralocorticoid effects promote sodium and water retention, which can lead to edema, hypertension, and electrolyte imbalances. By reducing these unwanted properties, synthetic glucocorticoids provide effective anti-inflammatory therapy while lowering the risk of fluid retention and cardiovascular complications. The result of these advances is a diverse range of corticosteroids with varying potencies, durations of action, and mineralocorticoid effects. Understanding the differences between natural cortisol and synthetic glucocorticoids is essential for selecting the most appropriate agent for each clinical situation and achieving the best therapeutic outcomes. One of the most important ways glucocorticoids exert their therapeutic effects is through genomic mechanisms known as transactivation. This process explains many of the powerful anti-inflammatory and immunomodulatory actions of corticosteroid drugs. Although the mechanism appears complex, it can be understood as a series of carefully coordinated cellular events that ultimately change gene expression. The process begins because glucocorticoids are highly lipophilic molecules. Being fat-soluble allows them to pass easily through the phospholipid cell membrane without requiring transporters or surface receptors. Once inside the cell, the glucocorticoid molecule encounters its primary target, the cytosolic glucocorticoid receptor, commonly known as GR-alpha. In its inactive state, the glucocorticoid receptor is not free-floating. Instead, it exists as part of a large protein complex associated with specialized chaperone proteins. These include heat shock protein 90, or HSP90, and heat shock protein 70, or HSP70. These chaperone proteins stabilize the receptor and maintain it in a conformation capable of binding corticosteroids. When a glucocorticoid molecule binds to cytosolic glucocorticoid receptor, a major structural change occurs. The receptor becomes activated and the attached heat shock proteins dissociate from the complex. This dissociation is a critical step because it exposes important functional regions of the receptor that are required for the next phase of signaling. Following activation, two glucocorticoid receptor molecules bind together to form a homodimer. This dimerized receptor drug complex is then transported into the cell nucleus through nuclear pores. The nucleus serves as the control center of the cell, housing the genetic material that directs cellular function. Once inside the nucleus, the activated receptor complex interacts directly with DNA. It binds to specific regulatory DNA sequences called glucocorticoid response elements, or GREs. In the case of transactivation, the receptor binds to positive GREs that promote gene transcription. This interaction stimulates the production of messenger RNA, leading to increased synthesis of specific proteins. One particularly important protein produced through this mechanism is annexin A1, also known as lipocortin-1. Annexin A1 plays a major role in suppressing inflammation. It inhibits phospholipase A2, an enzyme responsible for releasing arachidonic acid from cell membranes. Since arachidonic acid is the precursor for prostaglandins and leukotrienes, reducing its availability significantly decreases the production of inflammatory mediators. The result is a powerful reduction in inflammation, tissue swelling, pain, and immune activation. Because genomic mechanisms require gene transcription and protein synthesis, their effects are not immediate. Instead, they typically develop over several hours. However, once established, these effects can be profound and long-lasting. Through transactivation, glucocorticoids essentially reprogram cellular activity, increasing the production of anti-inflammatory proteins and helping restore physiological balance during inflammatory and immune-mediated diseases. While transactivation increases the production of anti-inflammatory proteins, another equally important genomic mechanism is known as transrepression. In fact, many of the powerful anti-inflammatory and immunosuppressive effects of glucocorticoids are largely attributed to this process. Rather than turning genes on, transrepression works by switching inflammatory genes off. The process begins when a glucocorticoid enters the cell and binds to the cytosolic glucocorticoid receptor. After activation, the receptor moves into the nucleus, where it influences gene expression. However, unlike transactivation, transrepression often does not involve direct binding to DNA. Instead, the activated glucocorticoid receptor acts through protein-protein interactions with key transcription factors that normally promote inflammation. One important feature of transrepression is that the glucocorticoid receptor frequently functions as a monomer rather than a homodimer. In this form, it physically interacts with transcription factors and prevents them from activating inflammatory genes. This mechanism allows glucocorticoids to exert broad anti-inflammatory effects across many different cell types. Two of the most important targets are nuclear factor kappa B, commonly known as NF-kappa B, and activator protein 1, or AP1. These transcription factors serve as major regulators of inflammation. Under normal inflammatory conditions, they enter the nucleus and stimulate the expression of numerous genes involved in immune activation and tissue injury. Nuclear factor kappa B is responsible for promoting the synthesis of many inflammatory mediators. It activates genes that produce cytokines, adhesion molecules, and enzymes involved in inflammation. Activator protein 1 performs a similar role and contributes to cellular proliferation, immune responses, and inflammatory signaling pathways. Together, these transcription factors act as central switches that drive inflammatory reactions. Activated glucocorticoid receptors interfere with the activity of nuclear factor kappa B and activator protein 1. By binding to these transcription factors, the receptor prevents them from interacting effectively with DNA. As a result, the transcription of many pro-inflammatory genes is markedly reduced. One major consequence is the downregulation of inflammatory cytokines. The production of interleukin-1, interleukin-2, interleukin-6, and tumor necrosis factor alpha is significantly suppressed. These cytokines normally amplify inflammation, recruit immune cells, and promote tissue damage. Reducing their production helps control excessive immune responses and limits inflammatory injury. Transrepression also decreases the expression of important inflammatory enzymes. One key target is cyclooxygenase 2, or COX-2. This enzyme is responsible for generating prostaglandins that contribute to pain, fever, redness, and swelling. By reducing cyclooxygenase 2 transcription, glucocorticoids decrease prostaglandin synthesis and lessen inflammatory symptoms. Another important target is inducible nitric oxide synthase, or INOS. This enzyme produces large amounts of nitric oxide during inflammation. Excess nitric oxide can contribute to vasodilation, tissue injury, and inflammatory damage. Suppression of inducible nitric oxide synthase helps further reduce inflammatory activity. Through transrepression, glucocorticoids effectively silence many of the genes that drive inflammation. This powerful genomic mechanism explains why corticosteroids remain among the most effective anti-inflammatory and immunosuppressive drugs in modern medicine. Most discussions about glucocorticoids focus on the genomic effects, which involve changes in gene transcription and usually take several hours to develop. However, glucocorticoids can also produce rapid non-genomic effects that occur much faster. These actions are especially important during medical emergencies, where immediate physiological responses are needed. Unlike genomic mechanisms, non-genomic effects do not depend on altering DNA transcription or synthesizing new proteins. Instead, they occur within seconds to minutes after drug administration. This rapid onset allows glucocorticoids to influence cellular function long before genomic effects become apparent. One mechanism involves specialized membrane-bound glucocorticoid receptors, often referred to as MGCRs. These receptors are located on the cell surface rather than inside the cytoplasm. When glucocorticoids bind to these membrane receptors, they trigger intracellular signaling pathways that rapidly modify cellular activity. These signaling cascades can alter ion channel function, enzyme activity, and cellular communication without directly affecting gene expression. Another important non-genomic mechanism is related to the physiochemical properties of glucocorticoids. Because these drugs are highly lipophilic, they can directly interact with cellular membranes. Glucocorticoid molecules insert themselves into the lipid bilayer of cell membranes, a process known as intercalation. This interaction changes membrane fluidity and stability, influencing the behavior of membrane-associated proteins and signaling molecules. These rapid membrane effects can quickly modify cellular responses during acute inflammation and stress. For example, Glucocorticoids can reduce the activation of inflammatory cells and limit the release of chemical mediators that contribute to tissue injury. These effects occur much faster than genomic mechanisms and help explain the immediate benefits sometimes observed after corticosteroid administration. A clinically important example involves mast cells. Mast cells play a central role in allergic and inflammatory reactions by releasing histamine, leukotrienes, and other potent mediators through a process known as degranulation. Excessive mast cell activation can lead to bronchoconstriction, vasodilation, tissue swelling, and allergic symptoms. Non-genomic glucocorticoid actions can rapidly reduce mast cell degranulation, helping to limit the release of these inflammatory substances. Another important effect is the restoration of vascular tone. During severe inflammatory states, septic shock, or anaphylactic reactions, blood vessels may become excessively dilated, leading to dangerously low blood pressure. Rapid non-genomic glucocorticoid effects help improve vascular responsiveness to endogenous catecholamines and vasopressor agents. This contributes to improved blood pressure regulation and cardiovascular stability. In acute asthma exacerbations, these rapid actions may also help reduce airway inflammation and improve responsiveness to bronchodilator therapy. Although corticosteroids are traditionally considered slower-acting medications, their non-genomic effects provide important early benefits while longer-lasting genomic mechanisms are still developing. In summary, non-genomic glucocorticoid actions occur within seconds to minutes and involve membrane-bound receptors, intracellular signaling pathways, and direct interactions with cellular membranes. These rapid effects play a valuable role in reducing inflammation, stabilizing mast cells, restoring vascular tone, and supporting patients during acute medical emergencies. Understanding the pharmacokinetics of corticosteroids is essential for appreciating how these drugs achieve their therapeutic effects. Pharmacokinetics describes what the body does to a drug, including its absorption, distribution, metabolism, and elimination. One of the reasons corticosteroids are so versatile is that they can be administered through multiple routes, allowing treatment to be tailored to specific diseases and patient needs. A key feature of corticosteroids is their highly lipophilic nature. Because they are fat-soluble molecules, they can readily cross biological membranes. This property allows many corticosteroids to be efficiently absorbed from the gastrointestinal tract following oral administration. As a result, most oral corticosteroid preparations exhibit excellent bioavailability, meaning that a large proportion of the administered dose reaches the systemic circulation and becomes available for therapeutic action. Oral administration remains one of the most common routes of corticosteroid therapy. These medications are available as tablets, capsules, and liquid solutions. Oral corticosteroids are widely used for conditions such as autoimmune diseases, severe allergic reactions, inflammatory disorders, and chronic respiratory illnesses. Their convenience and effectiveness make them a cornerstone of corticosteroid treatment. In situations requiring rapid intervention, systemic corticosteroids may be administered intravenously or intramuscularly. Intravenous administration provides immediate drug delivery into the bloodstream, making it particularly valuable in emergencies such as severe asthma exacerbations, anaphylaxis, adrenal crisis, or septic shock. Intramuscular injections can also provide sustained systemic effects when oral therapy is impractical or contraindicated. While systemic administration is highly effective, it exposes the entire body to the drug and may increase the risk of adverse effects. For this reason, Targeted delivery systems have been developed to concentrate therapy at the site of disease while minimizing systemic exposure. Inhaled corticosteroids are a prime example of targeted therapy. Delivered directly into the airways, these medications are fundamental in the management of asthma and other chronic inflammatory respiratory conditions. By acting locally within the lungs, inhaled corticosteroids effectively reduce airway inflammation while limiting systemic absorption. Similarly, intranasal corticosteroids are commonly used to treat allergic rhinitis. Administered as nasal sprays, they reduce nasal congestion, sneezing, itching, and rhinorrhea by suppressing inflammation directly within the nasal mucosa. Because the drug is delivered precisely where it is needed, systemic side effects are generally minimal. Topical corticosteroids are another important form of targeted therapy. Applied directly to the skin, they are used to manage a wide range of inflammatory dermatoses, including eczema, psoriasis, and contact dermatitis. Localized application helps control inflammation, redness, itching, and swelling while minimizing systemic drug exposure. For patients with localized joint inflammation, corticosteroids may be administered through intra-articular injection. This technique delivers the drug directly into the affected joint space, providing potent anti-inflammatory effects in conditions such as osteoarthritis, rheumatoid arthritis, and bursitis. The localized delivery allows high concentrations at the site of inflammation with reduced systemic effects. The availability of multiple administration routes makes corticosteroids highly adaptable therapeutic agents. By selecting the most appropriate route, clinicians can maximize efficacy, target disease more precisely, and minimize unwanted adverse effects. After corticosteroids enter the bloodstream, they do not circulate entirely as free molecules. Instead, most of the drug binds to plasma proteins that transport it throughout the body. This process of distribution and protein binding plays a major role in determining how much drug reaches target tissues, how long it remains in circulation, and how strongly it exerts its effects. The two most important plasma proteins involved in corticosteroid transport are corticosteroid binding globulin, commonly known as CBG or transcortin, and albumin. Together, these proteins act as carriers that transport corticosteroids through the bloodstream while regulating the amount of free, active drug available to tissues. Corticosteroid binding globulin is the primary transport protein for endogenous cortisol. It is characterized as a high-affinity, low-capacity binding protein. High affinity means that corticosteroid binding globulin binds cortisol very tightly. However, because it has a relatively low capacity, only a limited amount of hormone can be carried at any given time. This strong binding helps stabilize circulating cortisol concentrations and serves as a reservoir that can release hormone when needed. Albumin functions differently. It is considered a low-affinity, high-capacity binding protein. Albumin does not bind corticosteroids as tightly as corticosteroid binding globulin, but it is present in very large quantities in the plasma. Because of its abundance, albumin can carry substantial amounts of corticosteroids despite its weaker binding strength. In many situations, albumin acts as an important secondary transport system. An important pharmacological principle is that only the free, unbound fraction of a corticosteroid is biologically active. Protein-bound corticosteroids are generally unable to cross cell membranes or interact with intracellular glucocorticoid receptors. Only when the drug dissociates from its carrier protein can it enter tissues and produce pharmacological effects. The free fraction is therefore responsible for therapeutic actions such as anti-inflammatory activity, immunosuppression, and metabolic regulation. Changes in protein binding can significantly influence drug response. For example, alterations in plasma protein concentrations during pregnancy, liver disease, severe illness, or malnutrition may affect the proportion of free corticosteroid available for action. Endogenous cortisol shows a strong preference for binding to corticosteroid binding globulin. Under normal physiological conditions, most circulating cortisol is attached to this specialized carrier protein, while only a small percentage remains free and biologically active. This arrangement allows the body to carefully regulate cortisol availability and maintain hormonal balance. Synthetic corticosteroids often behave differently. Many synthetic agents, including dexamethasone, have a much lower affinity for corticosteroid binding globulin and rely more heavily on albumin for transport. Because albumin binds drugs less tightly than corticosteroid binding globulin, a larger proportion of synthetic corticosteroids may remain free in circulation. This contributes to their potent pharmacological activity and influences their distribution characteristics. Understanding protein binding is essential because it helps explain differences in drug potency, duration of action, tissue distribution, and clinical response. The balance between protein-bound and free corticosteroid ultimately determines how much active drug reaches target cells and produces therapeutic effects. Once corticosteroids have produced their therapeutic effects, the body must metabolize and eliminate them efficiently. This process occurs primarily in the liver and is a critical determinant of drug duration, efficacy, and safety. Understanding corticosteroid metabolism is especially important because many drug interactions arise from alterations in these metabolic pathways. The liver serves as the principal site of corticosteroid biotransformation. Most corticosteroids undergo phase 1 metabolism through the cytochrome P450 enzyme system. Among these enzymes, cytochrome P453A4, commonly known as CYP3A4, plays the dominant role. CYP3A4 is one of the most important drug metabolizing enzymes in the human body and is responsible for processing a wide range of medications. During phase 1 metabolism, CYP3A4 chemically modifies corticosteroid molecules through oxidation and related reactions. These structural changes generally reduce biological activity and prepare the drug for subsequent metabolic processing. The efficiency of CYP3A4 activity directly influences how quickly corticosteroids are cleared from the circulation. Following phase 1 metabolism, corticosteroids undergo phase 2 metabolism. In this stage, the modified drug molecules are conjugated with water-soluble groups through processes such as glucuronidation and sulfation. These reactions significantly increase the solubility of corticosteroid metabolites, allowing them to be transported more easily in the bloodstream and excreted through the kidneys. The resulting metabolites are primarily eliminated in the urine. Through the combined actions of phase 1 and phase 2 metabolism, the body effectively terminates corticosteroid activity and prevents excessive accumulation of these potent hormones and medications. A clinically important feature of CYP3A4 is its susceptibility to drug interactions. Certain medications can induce CYP3A4 activity, causing the enzyme to work more rapidly than normal. These agents are known as CYP3A4 inducers. Common examples include phenytoin, rifampin, and phenobarbital. When these drugs are administered alongside corticosteroids, metabolism accelerates and corticosteroid clearance increases. As a result, plasma drug concentrations may fall below therapeutic levels. Patients may experience inadequate disease control, worsening inflammation, or treatment failure because the corticosteroid is being eliminated too quickly. In some cases, higher corticosteroid doses may be required to achieve the desired clinical effect. Conversely, some medications inhibit CYP3A4 activity. These CYP3A4 inhibitors reduce the enzyme's ability to metabolize corticosteroids, causing drug clearance to slow. Important examples include ketoconazole, ritonavir, and clarithromycin. When corticosteroids are taken with these medications, plasma concentrations can rise substantially. Elevated corticosteroid levels increase the risk of adverse effects and toxicity. Patients may develop hyperglycemia, fluid retention, hypertension, mood changes, immunosuppression, or manifestations of iatrogenic Cushing's syndrome. In severe cases, prolonged exposure may contribute to suppression of the hypothalamic-Pituitary-Adrenal axis. For this reason, clinicians must carefully evaluate potential drug interactions whenever corticosteroids are prescribed. A thorough understanding of CYP3A4-mediated metabolism helps optimize therapy, prevent treatment failure, minimize toxicity, and ensure safe and effective use of these powerful medications. An important aspect of corticosteroid pharmacokinetics involves the enzyme system known as 11-beta-hydroxysteroid dehydrogenase, or 11-beta-HSD. This enzyme system acts like a biological switch, controlling whether certain corticosteroids exist in their active or inactive forms. By regulating these conversions, 11-beta-hydroxysteroid dehydrogenase plays a critical role in hormone activity, drug effectiveness, and tissue-specific responses. There are two major forms of this enzyme, each with distinct functions and locations in the body. The first, 11-beta-hydroxysteroid dehydrogenase type 1, is found predominantly in the liver, although it is also present in adipose tissue and several other organs. This enzyme functions primarily as a reductase, meaning it converts inactive 11-keto compounds into their active 11-hydroxy forms. One of the most important examples is the conversion of cortisone into cortisol. Cortisone itself has relatively little glucocorticoid activity. However, once it reaches the liver, 11-beta-hydroxysteroid dehydrogenase type 1 transforms it into cortisol, the biologically active hormone responsible for regulating metabolism, immune responses, and inflammation. A similar process occurs with prednisone, one of the most commonly prescribed corticosteroids. Prednisone is considered a prodrug because it possesses limited activity until it undergoes metabolic activation. In the liver, 11-beta-hydroxysteroid dehydrogenase type 1 converts prednisone into prednisolone, the active form responsible for the drug's therapeutic effects. This conversion is essential for achieving the desired anti-inflammatory and immunosuppressive actions. Because of this activation step, the liver plays a crucial role in determining the effectiveness of certain corticosteroid therapies. When liver function is normal, conversion occurs efficiently and adequate levels of active drug are produced. However, when hepatic function is severely impaired, activation may be significantly reduced. The second enzyme, 11-beta-hydroxysteroid dehydrogenase type 2, performs the opposite function. It is found primarily in the kidneys, as well as in the colon, salivary glands, and placenta. Unlike type 1, this enzyme acts as an oxidase, converting active cortisol into inactive cortisone. This conversion serves an important protective purpose. Cortisol can bind not only to glucocorticoid receptors but also to mineralocorticoid receptors. Since cortisol circulates at much higher concentrations than aldosterone, it could potentially overstimulate mineralocorticoid receptors and disrupt sodium and water balance. By converting cortisol into inactive cortisone, 11-beta-hydroxysteroid dehydrogenase type 2 prevents inappropriate activation of these receptors and preserves normal electrolyte homeostasis. The clinical implications of this enzyme system are significant. Patients with severe hepatic failure may have a reduced ability to convert prodrugs such as prednisone into their active forms. In these situations, administering prednisolone directly is often preferred because it bypasses the need for hepatic activation. This ensures that adequate therapeutic concentrations are achieved despite impaired liver function. Understanding the roles of 11-beta-hydroxysteroid dehydrogenase type 1 and type 2 helps explain how corticosteroids are activated, inactivated, and regulated within different tissues. These enzymes are key determinants of both drug efficacy and physiological hormone balance. Short-acting corticosteroids represent the group of steroid medications that most closely resemble the body's natural cortisol production. These agents are particularly important because they provide both glucocorticoid and mineralocorticoid effects, making them useful for replacing hormones that the body can no longer produce adequately. The two principal short-acting corticosteroids are hydrocortisone and cortisone. Hydrocortisone is essentially the pharmaceutical form of cortisol, the major glucocorticoid naturally produced by the adrenal cortex. Cortisone, on the other hand, is an inactive precursor that must be converted in the liver to cortisol before it becomes fully active. These medications have a biological half-life of approximately 8 to 12 hours. This relatively short duration of action closely mirrors the body's normal physiological rhythm of cortisol secretion. Because of this, hydrocortisone is often administered in divided doses throughout the day to mimic natural hormone production as closely as possible. One of the defining characteristics of short-acting corticosteroids is their significant mineralocorticoid activity. Unlike many newer synthetic corticosteroids that have little or no effect on sodium balance, hydrocortisone retains substantial mineralocorticoid properties. In pharmacological terms, hydrocortisone is often considered to have a glucocorticoid to mineralocorticoid activity ratio of approximately 1:1. This means that hydrocortisone not only exerts anti-inflammatory and metabolic effects, but also promotes sodium retention and potassium excretion in the kidneys. These actions help maintain blood volume, blood pressure, and electrolyte balance. As a result, hydrocortisone more closely reproduces the physiological actions of endogenous adrenal hormones than many other corticosteroids. Because of these properties, the primary clinical use of hydrocortisone and cortisone is physiological replacement therapy. These drugs are especially valuable in patients with primary adrenal insufficiency, commonly known as Addison's disease. In this condition, the adrenal cortex is unable to produce adequate amounts of cortisol and often fails to produce sufficient aldosterone as well. Without treatment, patients may experience chronic fatigue, muscle weakness, weight loss, low blood pressure, dehydration, and electrolyte abnormalities. Hydrocortisone replacement helps restore normal glucocorticoid function and supports many essential physiological processes required for daily life. Hydrocortisone is also commonly used during periods of physiological stress in patients with adrenal insufficiency. During surgery, severe illness, trauma, or infection, the body's demand for cortisol increases dramatically. Additional hydrocortisone, often referred to as stress-dose steroid therapy, may be required to prevent adrenal crisis, a potentially life-threatening condition characterized by severe hypotension, shock, and circulatory collapse. Although short-acting corticosteroids are effective replacement agents, their mineralocorticoid activity may limit their use in situations where potent anti-inflammatory effects are desired without sodium and water retention. For this reason, longer-acting synthetic corticosteroids are often preferred for inflammatory and autoimmune disorders. Nevertheless, hydrocortisone and cortisone remain indispensable medications because they most closely replicate natural adrenal hormone function and provide life-saving replacement therapy for patients with adrenal insufficiency. Intermediate-acting corticosteroids are among the most frequently prescribed glucocorticoids in clinical practice. They offer an excellent balance between potency, duration of action, and safety, making them highly effective for treating a wide range of inflammatory and autoimmune disorders. Compared with natural cortisol, these agents provide stronger anti-inflammatory effects while producing considerably less mineralocorticoid activity. The most important drugs in this category include prednisone, prednisolone, methylprednisolone, and triamcinolone. Although these medications share many pharmacological properties, they differ slightly in potency, formulation, and clinical applications. Together, they form the backbone of systemic corticosteroid therapy in modern medicine. These drugs have a biological half-life of approximately 12 to 36 hours. This intermediate duration allows for sustained therapeutic effects while avoiding the prolonged tissue exposure associated with long-acting corticosteroids. In many cases, once-daily dosing is sufficient to achieve disease control, improving patient convenience and adherence to therapy. One of the major advantages of intermediate-acting corticosteroids is their enhanced glucocorticoid potency. Most agents in this group are approximately 4 to 5 times more potent than cortisol. This means that smaller doses can produce significant anti-inflammatory and immunosuppressive effects. Their increased potency results from structural modifications that improve receptor binding and biological activity. At the same time, these drugs exhibit markedly reduced mineralocorticoid activity. Unlike hydrocortisone, which promotes sodium and water retention, intermediate-acting corticosteroids have much less effect on electrolyte balance. As a result, they are less likely to cause fluid retention, edema, and hypertension when used at therapeutic doses. This reduced mineralocorticoid activity makes them particularly suitable for long-term treatment of inflammatory diseases. Prednisone is one of the most widely used corticosteroids in this group. It functions as a prodrug and must be converted in the liver to prednisolone, its active form. Prednisolone itself is pharmacologically active and is often preferred in patients with significant liver impairment. Methylprednisolone offers even less mineralocorticoid activity and is frequently used in severe inflammatory conditions requiring high-dose therapy. Triamcinolone is another potent glucocorticoid commonly utilized in systemic, topical, and intra-articular formulations. The primary clinical use of intermediate-acting corticosteroids is systemic anti-inflammatory and immunosuppressive therapy. In asthma, they reduce airway inflammation, improve lung function, and help prevent exacerbations. In rheumatoid arthritis, they decrease joint swelling, pain, and stiffness while slowing inflammatory damage. Patients with systemic lupus erythematosus often require corticosteroids to suppress abnormal immune activity and protect vital organs from autoimmune injury. These agents also play an important role in inflammatory bowel disease, including ulcerative colitis and Crohn's disease. By reducing intestinal inflammation, they help control symptoms such as abdominal pain, diarrhea, and rectal bleeding. Because of their favorable balance between efficacy and duration of action, intermediate-acting corticosteroids remain some of the most versatile and widely used medications in medicine. Their ability to control inflammation and suppress excessive immune responses has transformed the management of countless acute and chronic diseases. Long-acting corticosteroids represent the most potent group of synthetic glucocorticoids used in clinical medicine. These agents are specifically designed to provide powerful and prolonged anti-inflammatory effects while eliminating unwanted mineralocorticoid activity. Their unique pharmacological profile makes them invaluable in several severe and life-threatening medical conditions. The two principal drugs in this category are dexamethasone and betamethasone. Both are highly modified synthetic corticosteroids that possess exceptional glucocorticoid activity. Through strategic structural alterations of the steroid molecule, scientists created agents that are far more potent than natural cortisol and capable of exerting effects for extended periods. One defining feature of these drugs is their long biological half-life, which ranges from approximately 36 to 72 hours. This prolonged duration allows therapeutic effects to persist long after administration. As a result, less frequent dosing is often required compared with short-acting and intermediate-acting corticosteroids. However, their extended action also means that physiological effects can continue for several days after a single dose. Another remarkable characteristic is their extraordinary glucocorticoid potency. Dexamethasone and betamethasone are approximately 25 to 30 times more potent than cortisol in terms of anti-inflammatory activity. This means that very small doses can produce profound suppression of inflammation and immune responses. Their high potency makes them particularly useful when rapid and aggressive control of inflammation is required. Equally important is the fact that these agents possess virtually no mineralocorticoid activity. Unlike hydrocortisone, they do not significantly promote sodium retention, water retention, or potassium excretion. This absence of mineralocorticoid effects reduces the risk of edema, fluid overload, and hypertension, making them especially suitable for conditions where fluid retention could worsen clinical outcomes. One major clinical application is the treatment of cerebral edema. Swelling of brain tissue can occur in association with brain tumors, neurosurgical procedures, traumatic brain injury, and other neurological disorders. Dexamethasone is particularly effective in reducing inflammation and decreasing intracranial pressure, helping preserve neurological function and relieve symptoms caused by brain swelling. Long-acting corticosteroids also gained global attention during the COVID-19 pandemic. In patients with severe COVID-19 requiring supplemental oxygen or mechanical ventilation, dexamethasone was shown to reduce mortality by dampening the excessive inflammatory response that contributes to lung injury and respiratory failure. Its potent anti-inflammatory action became an important component of treatment protocols for critically ill patients. Another important use involves promoting fetal lung maturity. When preterm delivery is anticipated, betamethasone or dexamethasone may be administered to the mother before birth. These corticosteroids accelerate the production of pulmonary surfactant within the fetal lungs, reducing the risk of neonatal respiratory distress syndrome and improving survival in premature infants. Because of their prolonged duration and high potency, long-acting corticosteroids must be used carefully. While they provide powerful therapeutic benefits, they also carry a greater potential for adverse effects and hypothalamic-pituitary-adrenal axis suppression when used for prolonged periods. Nevertheless, in selected clinical situations, they remain among the most valuable drugs available in modern medicine. Understanding corticosteroid potency is essential for selecting the right drug for the right patient. Not all corticosteroids produce the same effects. Some primarily provide glucocorticoid activity, which suppresses inflammation and modulates immune responses. Others exert significant mineralocorticoid activity, which regulates sodium retention, potassium excretion, blood volume, and blood pressure. Comparing these activities helps clinicians choose the most appropriate corticosteroid for specific clinical situations. Hydrocortisone serves as the reference standard against which other corticosteroids are compared. Because hydrocortisone is essentially pharmaceutical cortisol, its glucocorticoid activity is assigned a value of 1, and its mineralocorticoid activity is also assigned a value of 1. This balanced profile closely resembles the natural hormone produced by the adrenal cortex. As a result, hydrocortisone is particularly useful for physiological hormone replacement in patients with adrenal insufficiency. Prednisone represents the next step in corticosteroid development. Compared with hydrocortisone, prednisone possesses approximately 4 times greater glucocorticoid activity. This increased potency allows smaller doses to achieve substantial anti-inflammatory effects. At the same time, its mineralocorticoid activity is reduced to about 0.8. Although some sodium-retaining effects remain, they are considerably less pronounced than those of hydrocortisone. This balance makes prednisone a popular choice for many inflammatory and autoimmune disorders. Methylprednisolone provides an even greater separation between glucocorticoid and mineralocorticoid actions. Its glucocorticoid potency is approximately 5 times that of hydrocortisone, while its mineralocorticoid activity is reduced to about 0.5. This means that methylprednisolone delivers powerful anti-inflammatory effects with relatively little fluid retention. For this reason, it is often preferred in conditions requiring high-dose corticosteroid therapy. Dexamethasone occupies the extreme end of the glucocorticoid spectrum. Its glucocorticoid activity is approximately 25 to 30 times greater than that of hydrocortisone. Despite this remarkable potency, dexamethasone possesses essentially no mineralocorticoid activity. It does not significantly promote sodium retention or water retention. This unique profile makes dexamethasone highly valuable in conditions such as cerebral edema, severe inflammatory states, and critical illnesses where fluid accumulation would be undesirable. At the opposite end of the spectrum is fludrocortisone. Unlike most corticosteroids, fludrocortisone is used primarily for its mineralocorticoid effects rather than its glucocorticoid actions. Although it has a glucocorticoid potency of approximately 10 times that of hydrocortisone, its most striking feature is its mineralocorticoid activity, which is roughly 250 times greater than that of cortisol. This extraordinary sodium-retaining effect makes fludrocortisone the drug of choice for mineralocorticoid replacement therapy. Patients with primary adrenal insufficiency often require fludrocortisone to replace the aldosterone that their adrenal glands can no longer produce. By promoting sodium retention and maintaining blood pressure, fludrocortisone helps prevent dehydration, hypotension, and electrolyte disturbances. These differences in glucocorticoid and mineralocorticoid potency explain why corticosteroids are not interchangeable. Understanding these pharmacological profiles allows clinicians to tailor therapy, maximize benefits, and minimize unwanted adverse effects. Corticosteroids are among the most effective anti-inflammatory and immunosuppressive drugs available. They can rapidly relieve symptoms, control disease activity, and even save lives in critical situations. However, their benefits must always be balanced against the potential for adverse effects. The type and severity of these effects often depend on the dose used and the duration of therapy. Short-term corticosteroid use, typically less than 2 weeks, is generally considered relatively safe. Nevertheless, even brief courses can produce noticeable side effects. One of the most common complaints is insomnia. Many patients report difficulty falling asleep or staying asleep, particularly when corticosteroids are taken later in the day. This occurs because glucocorticoids can stimulate the central nervous system and increase alertness. Mood changes may also occur during short-term therapy. Some individuals experience irritability, anxiety, restlessness, or emotional instability. In more severe cases, patients may develop hypomania, characterized by elevated mood, increased energy, and reduced need for sleep. Rarely, high doses can trigger steroid-induced psychosis, resulting in hallucinations, delusions, or significant behavioral disturbances. Acute hyperglycemia is another important short-term effect. Corticosteroids increase glucose production in the liver and reduce glucose uptake by tissues. As a result, blood sugar levels may rise, especially in patients with diabetes or those at risk of developing the condition. Careful monitoring may be required during therapy. Laboratory changes can also occur. Corticosteroids often cause leukocytosis, an increase in circulating white blood cell counts. This effect is largely due to demargination, a process in which white blood cells that normally adhere to blood vessel walls are released into the circulation. Although the white blood cell count rises, this does not necessarily indicate infection. Short-term corticosteroid use may also increase the risk of peptic ulcer disease, particularly when combined with non-steroidal anti-inflammatory drugs, commonly known as NSAIDs. The combination can increase gastrointestinal irritation and elevate the risk of ulcer formation and bleeding. Long-term corticosteroid therapy carries a much greater risk of serious complications. One of the most recognizable consequences is iatrogenic Cushing's syndrome. This condition results from prolonged exposure to high glucocorticoid levels and produces characteristic physical features. Patients may develop central obesity, a rounded moon-shaped face, and fat accumulation over the upper back, commonly referred to as a buffalo hump. Chronic corticosteroid use also causes profound immunosuppression. While this effect is beneficial for controlling autoimmune and inflammatory diseases, it can increase susceptibility to infections. Opportunistic pathogens that rarely cause disease in healthy individuals may become significant threats in immunosuppressed patients. The skin is particularly vulnerable to long-term steroid exposure. Patients often develop skin thinning, making the skin fragile and more easily injured. Stretch marks, known as striae, may appear, especially over the abdomen, thighs, and arms. Easy bruising becomes common because blood vessels and connective tissues become more fragile. Another important complication is proximal myopathy. This condition causes weakness of the muscles closest to the trunk, particularly those of the shoulders and hips. Patients may notice difficulty climbing stairs, rising from a chair, or lifting objects. These effects highlight the importance of using corticosteroids carefully and monitoring patients during prolonged therapy. While corticosteroids are highly effective medications, prolonged use can lead to important metabolic, skeletal, vascular, and ophthalmic complications. These adverse effects often develop gradually and may become clinically significant after months or years of therapy. Understanding these complications is essential for balancing therapeutic benefits against long-term risks. One of the most serious consequences of chronic corticosteroid therapy is steroid-induced osteoporosis. Bone is a dynamic tissue that constantly undergoes remodeling through the coordinated actions of osteoblasts, which build bone, and osteoclasts, which break it down. Corticosteroids disrupt this balance by suppressing osteoblast activity while simultaneously promoting osteoclast activity. As a result, bone formation decreases and bone resorption increases. Over time, bones become thinner, weaker, and more fragile. Patients may experience a progressive loss of bone mineral density, increasing their risk of fractures. The vertebrae, ribs, and hip are particularly vulnerable. In some cases, fractures may occur after only minor trauma or even normal daily activities. Another important skeletal complication is avascular necrosis, also known as osteonecrosis. This condition occurs when blood supply to a section of bone becomes compromised, leading to bone cell death. The femoral head, which forms part of the hip joint, is the most commonly affected site. Patients with avascular necrosis often develop gradually worsening hip pain, stiffness, and reduced mobility. If untreated, the damaged bone may collapse, resulting in severe joint dysfunction and the possible need for joint replacement surgery. Although relatively uncommon, this complication is considered one of the most serious adverse effects of long-term corticosteroid use. Corticosteroids also have significant metabolic effects. These drugs promote hepatic gluconeogenesis, a process in which the liver produces glucose from non-carbohydrate sources such as amino acids and glycerol. At the same time, corticosteroids reduce the sensitivity of peripheral tissues to insulin, creating a state of insulin resistance. The combination of increased glucose production and impaired glucose utilization can lead to persistent elevations in blood sugar levels. This diabetogenic effect may worsen existing diabetes or contribute to the development of steroid-induced diabetes in susceptible individuals. Careful monitoring of blood glucose is therefore important during prolonged therapy. The eyes are another target of corticosteroid toxicity. One well-recognized complication is the development of posterior subcapsular cataracts. These cataracts form beneath the posterior portion of the lens and can progressively impair vision. Patients may notice blurred vision, glare, or difficulty reading and performing daily activities. Corticosteroids can also increase intraocular pressure by interfering with normal drainage of aqueous humor within the eye. Persistent elevation of intraocular pressure may lead to glaucoma, a condition capable of causing progressive optic nerve damage and irreversible vision loss if left untreated. Because these complications can significantly affect quality of life, patients receiving long-term corticosteroid therapy require regular monitoring. Early detection of bone loss, metabolic abnormalities, vascular complications, and ocular changes allows timely intervention and helps minimize the long-term consequences of treatment while preserving the substantial therapeutic benefits of corticosteroids. The hypothalamic-Pituitary-Adrenal, or HPA, axis is the body's natural stress response system. It regulates the production of cortisol, a hormone that helps maintain blood pressure, blood sugar levels, metabolism, and the body's response to stress. When patients take corticosteroids for long periods, the body senses that enough steroid hormone is already present. As a result, the hypothalamus reduces the release of corticotropin-releasing hormone, or CRH. The pituitary gland also decreases the secretion of adrenocorticotropic hormone, known as ACTH. This continuous negative feedback effectively shuts down the normal hypothalamic-pituitary-adrenal axis. Over time, the adrenal glands become less active. Because adrenocorticotropic hormone normally stimulates adrenal growth and function, the lack of this trophic support causes the zona fasciculata and zona reticularis of the adrenal cortex to shrink. This process is known as adrenal atrophy. As the glands atrophy, their ability to produce cortisol becomes significantly impaired. The major danger occurs when long-term steroid therapy is stopped suddenly. The suppressed adrenal glands cannot immediately resume normal cortisol production. During this period, the body may experience acute adrenal insufficiency, also called an adrenal crisis. Symptoms can include severe weakness, nausea, vomiting, abdominal pain, hypoglycemia, and profound hypotension. If left untreated, adrenal crisis can be life-threatening. To prevent these complications, corticosteroids should usually be withdrawn gradually. Tapering allows the hypothalamus, pituitary gland, and adrenal cortex time to recover their normal function. The dose is slowly reduced over weeks or months, depending on the duration and intensity of therapy. Another useful strategy is alternate day dosing. By administering steroids every other day, periods of reduced steroid exposure allow partial recovery of adrenocorticotropic hormone secretion and adrenal activity. This approach may help preserve hypothalamic-pituitary-adrenal axis function in selected patients who require long-term treatment. Careful tapering and monitoring are essential whenever prolonged corticosteroid therapy is discontinued. These measures reduce the risk of adrenal crisis and support the safe restoration of the body's natural cortisol production. Here is an expanded, video-friendly version suitable for short 6 to 8 second clips. Adrenal insufficiency occurs when the body cannot produce enough cortisol to meet its daily needs. Cortisol is essential for maintaining blood pressure, blood sugar, energy balance, and the body's response to stress. The condition can arise from problems in the adrenal glands themselves or from disorders affecting the brain's hormonal control centers. Primary adrenal insufficiency, also known as Addison's disease, results from direct damage to the adrenal cortex. The most common cause is autoimmune destruction, where the immune system mistakenly attacks adrenal tissue. Other causes include infections such as tuberculosis, adrenal hemorrhage, metastatic cancer, or infiltrative diseases. In primary adrenal insufficiency, all three layers of the adrenal cortex are affected. The zona glomerulosa can no longer produce adequate aldosterone. The zona fasciculata fails to produce sufficient cortisol. The zona reticularis also loses its ability to make adrenal androgens. As a result, patients develop deficiencies in all three hormone groups. Because cortisol levels fall, the normal negative feedback on the hypothalamus and pituitary gland is lost. The pituitary responds by producing large amounts of adrenocorticotropic hormone, or ACTH. At the same time, production of its precursor molecule, propiomelanocortin, or POMC, also increases. This leads to excess melanocyte-stimulating activity and causes the characteristic skin hyperpigmentation often seen in Addison's disease. Secondary adrenal insufficiency has a different origin. Here, the adrenal glands are usually structurally normal. The problem lies in the pituitary gland or hypothalamus. Tumors, radiation therapy, traumatic brain injury, surgery, or other disorders can impair adrenocorticotropic hormone production. Without sufficient adrenocorticotropic hormone stimulation, the adrenal cortex produces less cortisol. However, aldosterone secretion remains largely normal because it is controlled mainly by the renin-angiotensin-aldosterone system rather than adrenocorticotropic hormone. For this reason, severe salt wasting and hyperkalemia are less common in secondary adrenal insufficiency. Another important form is iatrogenic adrenal insufficiency. This occurs when patients receive corticosteroid medications for prolonged periods. Continuous exposure to external steroids suppresses the hypothalamic-Pituitary-Adrenal, or HPA, axis through negative feedback. Over time, adrenocorticotropic hormone secretion decreases and the adrenal cortex undergoes atrophy. If corticosteroids are stopped abruptly, the suppressed adrenal glands may be unable to produce adequate cortisol. This can result in adrenal insufficiency and, in severe cases, a life-threatening adrenal crisis. Careful dose tapering allows the hypothalamic-Pituitary-Adrenal axis to recover and reduces this risk. Understanding the differences between primary, secondary, and iatrogenic adrenal insufficiency is essential because the underlying causes, hormone deficiencies, and treatment approaches are not the same. Here is an expanded, YouTube-friendly narration suitable for short 6 to 8-second video clips. Meet Mr. Johnson, a 32-year-old man who has been feeling increasingly exhausted for several months. No matter how much he sleeps, he never seems to regain his energy. Simple daily activities have become difficult, and he often feels weak and unmotivated. These symptoms are classic clues that point toward adrenal insufficiency. One of the most important functions of cortisol is helping the body maintain energy balance. When cortisol levels fall, patients often experience profound fatigue and lethargy. This is not ordinary tiredness. It is a deep, debilitating exhaustion that can interfere with work, exercise, and everyday life. Low cortisol also affects glucose regulation. As a result, patients may develop episodes of hypoglycemia, especially during periods of fasting or illness. They may feel shaky, dizzy, or lightheaded. Weight loss is also common because cortisol deficiency often reduces appetite, leading to anorexia and decreased food intake. In primary adrenal insufficiency, there is another major problem. The adrenal glands cannot produce enough aldosterone. Aldosterone normally helps the kidneys retain sodium and water while excreting potassium. Without it, the body begins to lose excessive amounts of salt and fluid. As fluid volume decreases, blood pressure drops. Patients frequently develop postural hypotension, meaning they feel dizzy or faint when standing up quickly. Some may even experience episodes of syncope. Because the body is losing sodium, many patients develop intense salt cravings as a natural attempt to restore electrolyte balance. Laboratory tests often reveal characteristic abnormalities. Sodium levels become low, a condition known as hyponatremia. Potassium levels rise, resulting in hyperkalemia. Reduced hydrogen ion excretion can also lead to a non-anion gap metabolic acidosis. One of the most striking features of primary adrenal insufficiency is skin hyperpigmentation. As cortisol levels decline, the pituitary gland responds by producing more adrenocorticotropic hormone. Increased adrenocorticotropic hormone production is accompanied by elevated levels of related peptides that stimulate melanin production. Over time, the skin develops a distinctive bronze or tanned appearance, even without increased sun exposure. This darkening is especially noticeable in the palmar creases, inside the mouth on the buccal mucosa, around scars, and in areas exposed to friction. For patients like Mr. Johnson, the combination of severe fatigue, weight loss, low blood pressure, salt craving, and bronze skin provides important diagnostic clues. Together, these hallmark findings create the classic clinical picture of primary adrenal insufficiency, also known as Addison's disease. The cornerstone of adrenal insufficiency treatment is hormone replacement therapy. Since the adrenal glands can no longer produce adequate cortisol, the goal is to replace this essential hormone as closely as possible to the body's natural production pattern. In healthy individuals, cortisol follows a circadian rhythm. Levels are highest in the early morning, helping us wake up and prepare for the day. They gradually decline throughout the afternoon and evening, reaching their lowest levels during sleep. Effective treatment aims to mimic this natural rhythm. The preferred medication is hydrocortisone, which is chemically identical to the cortisol produced by the human adrenal cortex. Because it closely resembles the body's natural hormone, it provides physiologic replacement and is generally well tolerated. Most adults require a total daily hydrocortisone dose of about 15 to 25 milligrams. Rather than taking the entire dose at once, it is usually divided into 2 or 3 doses throughout the day. The largest dose is taken immediately after waking, often 10 to 15 milligrams. This morning dose mimics the natural cortisol surge that normally occurs before and after awakening. A smaller dose is then taken in the early afternoon, typically 5 to 10 milligrams. This helps maintain adequate cortisol levels during the day while avoiding excessive exposure in the evening. Taking steroids too late in the day can interfere with sleep and disrupt normal circadian patterns. Some patients have difficulty adhering to multiple daily doses. In these situations, longer-acting glucocorticoids may be considered. Prednisone, usually given at 3 to 5 milligrams daily, is a common alternative. Another option is dexamethasone, which has a much longer half-life and can often be taken once daily at very low doses. However, longer-acting steroids may not replicate the normal cortisol rhythm as accurately as hydrocortisone. For this reason, hydrocortisone remains the preferred first-line replacement therapy whenever practical. An important part of patient education involves understanding sick day rules. During illness, injury, fever, infection, or periods of physical stress, healthy adrenal glands automatically increase cortisol production. Patients with adrenal insufficiency cannot make this adjustment on their own. To compensate, glucocorticoid doses must be increased during these stressful situations. In many cases, the usual dose is doubled or even tripled until recovery occurs. Minor surgical procedures may also require temporary dose escalation. Teaching patients when and how to adjust their medication is essential. Proper stress dosing helps prevent adrenal crisis, a potentially life-threatening emergency caused by severe cortisol deficiency. With appropriate replacement therapy and good education, most patients with adrenal insufficiency can lead active and healthy lives. In primary adrenal insufficiency, the adrenal glands lose their ability to produce aldosterone. Aldosterone is a vital hormone that helps the body maintain blood pressure, fluid balance, and normal electrolyte levels. Without it, the kidneys lose too much sodium and water while retaining excess potassium. This hormone deficiency can lead to dehydration, dizziness, low blood pressure, fatigue, and intense salt cravings. To correct these problems, patients require mineralocorticoid replacement therapy in addition to glucocorticoid replacement. The medication used for this purpose is fludrocortisone. Fludrocortisone is a synthetic corticosteroid with strong mineralocorticoid activity. It acts much like natural aldosterone and helps restore the body's ability to regulate salt and water balance. When fludrocortisone reaches the kidneys, it promotes sodium reabsorption and water retention. At the same time, it increases potassium excretion. These effects help expand blood volume, improve circulation, and stabilize blood pressure. For many patients, symptoms improve dramatically after treatment begins. Episodes of dizziness become less frequent. Energy levels often improve. Salt cravings decrease, and standing up from a sitting or lying position becomes easier. The usual dose of fludrocortisone ranges from 0.05 to 0.2 milligrams taken orally once each day. The exact dose varies from patient to patient. Treatment must be individualized to achieve the right balance between adequate replacement and excessive mineralocorticoid activity. Monitoring is an important part of therapy. One key goal is maintaining normal blood pressure. Patients should be able to stand upright without experiencing significant dizziness or lightheadedness. The absence of orthostatic symptoms is a useful sign that treatment is working effectively. Laboratory monitoring is equally important. Sodium levels should return to normal as the kidneys retain more salt. Potassium levels should also normalize as excess potassium is removed from the body. These laboratory changes provide valuable clues about the adequacy of replacement therapy. Another useful marker is plasma renin activity. Renin is released when the body senses low blood volume or insufficient aldosterone activity. In well-controlled patients, plasma renin activity is generally maintained in the upper half of the normal range. This helps clinicians fine-tune the fludrocortisone dose. Like all medications, fludrocortisone can cause side effects if too much is given. Excessive replacement may cause hypertension as blood volume increases beyond normal levels. Patients may also develop edema, which appears as swelling of the ankles, feet, or lower legs. Too much mineralocorticoid activity can also lower potassium levels excessively, resulting in hyperkalemia. This may cause muscle weakness, cramps, fatigue, or even cardiac rhythm abnormalities in severe cases. With proper dosing and regular monitoring, fludrocortisone effectively replaces lost aldosterone and plays a crucial role in the long-term management of primary adrenal insufficiency. An adrenal crisis is one of the most dangerous endocrine emergencies in clinical medicine. It occurs when the body experiences a sudden and severe deficiency of cortisol, and in many cases aldosterone as well. Without immediate treatment, the condition can rapidly progress to circulatory collapse and death. Adrenal crisis is most commonly triggered by a major physical stress. Severe infections, trauma, surgery, dehydration, or missed steroid doses are frequent causes. During these stressful situations, the body normally increases cortisol production several-fold. Patients with adrenal insufficiency cannot mount this life-saving response. The resulting hormone deficiency affects multiple organ systems. Cortisol is essential for maintaining blood pressure, blood glucose levels, vascular tone, and the body's ability to respond to stress. Aldosterone helps preserve sodium and water balance. When both hormones are deficient, cardiovascular stability is severely compromised. Patients often present with profound weakness and extreme fatigue. Severe hypotension develops as circulating blood volume falls and blood vessels become less responsive to catecholamines. In advanced cases, patients may progress to shock that does not respond adequately to standard vasopressor therapy. Gastrointestinal symptoms are also common. Many patients experience sudden abdominal pain, nausea, and repeated vomiting. Because these symptoms can resemble an acute surgical abdomen, adrenal crisis may sometimes be mistaken for other medical emergencies. Hypoglycemia is another important feature, particularly in children and vulnerable adults. Low cortisol levels impair glucose production by the liver, causing dangerously low blood sugar levels that can lead to confusion, seizures, or loss of consciousness. The cornerstone of treatment is immediate glucocorticoid replacement. Therapy should never be delayed while waiting for laboratory confirmation. The standard emergency regimen begins with hydrocortisone 100 mg administered intravenously as a rapid bolus injection. After the initial dose, hydrocortisone is continued at 50 mg intravenously every 6 hours. An alternative approach is continuous intravenous infusion at a total dose of 200 mg over 24 hours. These high doses rapidly restore cortisol activity and help stabilize cardiovascular function. Aggressive fluid resuscitation is equally important. Patients are usually severely volume depleted because of sodium and water loss. Rapid infusion of isotonic saline, also known as 0.9% sodium chloride, helps restore circulating blood volume and improve blood pressure. Because hypoglycemia is often present, dextrose-containing fluids may also be required. A common choice is 5% dextrose in normal saline, sometimes referred to as D5NS. This provides both glucose replacement and volume expansion. An important point to remember is that fludrocortisone is not required during the acute phase of adrenal crisis. High-dose hydrocortisone possesses sufficient mineralocorticoid activity to temporarily replace aldosterone. Fludrocortisone can be introduced later, once the patient is stabilized and hydrocortisone doses are reduced. Rapid recognition and immediate treatment are critical. In adrenal crisis, every minute matters, and prompt intervention can be life-saving. Cushing's syndrome is a disorder caused by prolonged exposure to excessive glucocorticoids. In most cases, the hormone involved is cortisol. While cortisol is essential for normal health, chronically elevated levels can have widespread and harmful effects throughout the body. Under normal circumstances, cortisol helps regulate metabolism, blood pressure, immune function, and the body's response to stress. However, when cortisol levels remain abnormally high for months or years, the body begins to develop the characteristic features of hypercortisolism. The causes of Cushing's syndrome can be divided into endogenous and exogenous forms. Endogenous causes arise from excessive cortisol production within the body. Exogenous causes result from the use of glucocorticoid medications. Most endogenous cases are adrenocorticotropic hormone dependent. In these disorders, excessive adrenocorticotropic hormone, or ACTH, stimulates the adrenal glands to produce too much cortisol. Adrenocorticotropic hormone-dependent causes account for approximately 80% of endogenous Cushing's syndrome. The most common adrenocorticotropic hormone-dependent cause is Cushing's disease. Despite the similar names, Cushing's disease is actually a specific subtype of Cushing's syndrome. It occurs when a pituitary adenoma secretes excessive amounts of adrenocorticotropic hormone. The overstimulated adrenal glands then produce excessive cortisol. Another adrenocorticotropic hormone-dependent cause is ectopic adrenocorticotropic hormone syndrome. In this condition, non-pituitary tumors produce adrenocorticotropic hormone independently. One classic example is small cell lung cancer. These tumors can release large amounts of adrenocorticotropic hormone, leading to severe and rapidly developing hypercortisolism. Approximately 20% of endogenous cases are adrenocorticotropic hormone independent. In these disorders, the adrenal glands themselves are responsible for excessive cortisol production. Adrenocorticotropic hormone levels are typically low because the high cortisol concentration suppresses pituitary hormone secretion through negative feedback. One common adrenocorticotropic hormone-independent cause is an adrenal adenoma. This benign tumor can autonomously secrete cortisol without normal hormonal regulation. A more serious cause is adrenocortical carcinoma, a malignant tumor capable of producing large quantities of cortisol. Another less common cause is macronodular adrenal hyperplasia. In this disorder, multiple enlarged adrenal nodules produce excess cortisol independently of adrenocorticotropic hormone control. Over time, this leads to persistent hypercortisolism and its associated complications. Globally, however, the most common cause of Cushing's syndrome is not a tumor at all. It is prolonged exposure to synthetic corticosteroids prescribed for conditions such as asthma, autoimmune diseases, inflammatory disorders, or organ transplantation. This form is known as exogenous or iatrogenic Cushing's syndrome. Long-term treatment with medications such as prednisone, dexamethasone, or methylprednisolone can produce the same clinical features seen with endogenous cortisol excess. Understanding the different causes of Cushing's syndrome is essential because treatment depends on identifying the source of cortisol excess. Whether the cause is a pituitary tumor, an adrenal lesion, an ectopic adrenocorticotropic hormone-producing cancer, or long-term steroid therapy, accurate diagnosis guides effective management. Meet Mrs. Chabet, a 45-year-old woman who has noticed significant changes in her appearance and overall health over the past several months. She has gained weight despite no major changes in her diet, feels weaker than before, and bruises easily. These are classic warning signs of Cushing's syndrome. One of the most recognizable features of Cushing's syndrome is abnormal fat redistribution. Excess cortisol changes the way the body stores fat. Instead of being distributed evenly, fat accumulates in specific areas of the body. Patients often develop central obesity, with increased fat around the abdomen and trunk. At the same time, the arms and legs may appear relatively thin. The face becomes round and full, creating the characteristic moon faces appearance. Fat can also accumulate over the upper back and neck, forming what is commonly called a buffalo hump. While fat is accumulating in some areas, cortisol is simultaneously breaking down protein throughout the body. This process is known as protein catabolism. Muscles are particularly affected. As muscle tissue is lost, patients develop proximal muscle weakness. Everyday activities such as climbing stairs, rising from a chair, or lifting objects overhead become increasingly difficult. Many patients describe feeling weak even though they appear overweight. The skin also becomes fragile. Cortisol reduces collagen production, causing the skin to become thin and delicate. Minor bumps or injuries may result in large bruises. Wound healing is often slower than normal. Another hallmark finding is the appearance of violaceous, or purple, abdominal striae. These stretch marks are typically wider and darker than those seen with ordinary weight gain. They commonly appear on the abdomen, thighs, breasts, and upper arms. Excess cortisol also has profound metabolic effects. It increases glucose production by the liver and promotes insulin resistance. Over time, this can lead to persistent hyperglycemia and the development of secondary diabetes mellitus. The cardiovascular system is affected as well. Many patients develop hypertension due to cortisol's effects on blood vessels and fluid balance. Elevated blood pressure is one of the most common complications of chronic hypercortisolism. At high concentrations, cortisol can also activate mineralocorticoid receptors. This causes the kidneys to retain sodium and excrete potassium. As a result, some patients develop hyperkalemia, which may contribute to muscle weakness, fatigue, and cardiac rhythm abnormalities. The skeletal system is another major target. Cortisol inhibits bone formation and accelerates bone breakdown. Over time, this leads to severe osteoporosis, increasing the risk of fractures even after minor trauma. In some cases, reduced blood supply to bone tissue can cause a vascular necrosis, particularly in weight-bearing joints such as the hips. This can lead to chronic pain and significant disability. For patients like Mrs. Chebet, the combination of central obesity, muscle weakness, fragile skin, diabetes mellitus, hypertension, and bone disease creates the classic clinical picture of Cushing's syndrome. The treatment of Cushing's syndrome begins with one important principle: identify and remove the source of excess cortisol. Because the condition is usually caused by a tumor or abnormal hormone production, surgery remains the primary and most effective treatment whenever possible. For patients with Cushing's disease, the preferred approach is transsphenoidal surgery. In this procedure, the surgeon removes the adrenocorticotropic hormone-secreting pituitary adenoma through the nasal passages. If the source of cortisol excess is an adrenal tumor, an adrenalectomy may be required to remove the affected adrenal gland. However, surgery is not always immediately possible. Some patients are too medically unstable for an operation. Others have persistent disease after surgery, recurrent disease months or years later, or tumors that cannot be easily located. In these situations, pharmacological therapy plays a critical role. Medications may be used before surgery to control severe symptoms and reduce cortisol levels. They can also serve as long-term treatment when surgery is contraindicated or when an ectopic adrenocorticotropic hormone-producing tumor remains hidden despite extensive investigations. Pharmacological management targets different points within the cortisol pathway. Understanding these targets helps explain how the available drugs work. The first group consists of steroidogenesis inhibitors. These medications act directly within the adrenal cortex and block the enzymes required for cortisol synthesis. As cortisol production falls, many of the metabolic and cardiovascular complications of Cushing's syndrome begin to improve. These drugs are often used as first-line medical therapy. The second group includes adrenoliptic agents. Rather than simply blocking hormone production, these drugs gradually damage and destroy cortisol-producing adrenal tissue. Over time, they induce toxic atrophy of the adrenal cortex, leading to a sustained reduction in cortisol secretion. Because of their potency, they require careful monitoring. A third strategy focuses on glucocorticoid receptor antagonists. These medications do not reduce cortisol levels directly. Instead, they block cortisol from binding to its receptors in target tissues. In effect, cortisol remains present in the bloodstream, but its harmful actions are greatly reduced. This approach can be particularly useful when rapid control of cortisol-related symptoms is needed. The fourth category targets the source of adrenocorticotropic hormone production itself. These neuromodulatory or pituitary-directed therapies are especially useful in patients with pituitary adenomas. By suppressing adrenocorticotropic hormone release, they reduce the stimulation of the adrenal glands and lower cortisol production indirectly. Each pharmacological approach addresses a different step in the disease process. Some drugs reduce cortisol synthesis. Others destroy adrenal tissue. Some block cortisol action, while others suppress adrenocorticotropic hormone secretion. The choice of therapy depends on the underlying cause of Cushing's syndrome, the severity of symptoms, the patient's overall health, and whether surgery is possible. When used appropriately, these medications can significantly improve symptoms, reduce complications, and help restore hormonal balance while definitive treatment is planned or when surgery is not an option. When treating Cushing's syndrome, one effective strategy is to block cortisol production directly within the adrenal glands. Two important medications used for this purpose are metyrapone and osilodrostat. These drugs belong to a class known as steroidogenesis inhibitors. To understand how they work, it helps to remember that cortisol is produced through a series of enzymatic steps inside the adrenal cortex. Each step depends on a specific enzyme that converts one hormone precursor into the next. Metyrapone and osilodrostat target one of the most important enzymes in this pathway, 11-beta-hydroxylase, also known as CYP11B1. This enzyme catalyzes the final step of cortisol synthesis. Normally, 11-beta-hydroxylase converts 11-deoxycortisol into cortisol. When the enzyme is blocked, this final conversion cannot occur. As a result, cortisol production falls, helping reduce the harmful effects of hypercortisolism. One major advantage of these medications is their rapid onset of action. Cortisol levels can begin to decline within hours to days after treatment is initiated. This makes them particularly useful for patients with severe symptoms who require relatively quick hormonal control. As cortisol levels decrease, patients may experience improvements in blood pressure, blood sugar control, muscle weakness, and many of the other complications associated with Cushing's syndrome. However, blocking one pathway in hormone synthesis can create unintended consequences. This is known as the shunting phenomenon. When cortisol production is interrupted, hormone precursors accumulate and are diverted into alternative steroid pathways. One consequence is increased production of androgen precursors. These androgen-related hormones can cause unwanted side effects, especially in women. Patients may develop hirsutism, which refers to excessive facial or body hair growth. Acne may also become more prominent because of increased androgen activity. Another consequence involves the accumulation of mineralocorticoid precursors. One important precursor is 11-deoxycorticosterone. Although it is not aldosterone, it possesses significant mineralocorticoid-like activity. As levels of this compound rise, the body begins to retain sodium and water. Blood pressure may increase, leading to hypertension. Fluid retention can also result in edema, causing swelling of the feet, ankles, or lower legs. At the same time, increased mineralocorticoid activity promotes potassium loss through the kidneys. This can lead to hyperkalemia, which may cause fatigue, muscle weakness, cramps, or even cardiac rhythm abnormalities in severe cases. Because of these potential adverse effects, patients receiving metyrapone or osilodrostat require regular monitoring of blood pressure, serum potassium levels, and overall clinical response. Dose adjustments are often necessary to achieve the right balance between lowering cortisol and minimizing side effects. Despite these challenges, metyrapone and osilodrostat remain valuable treatment options. Their ability to rapidly suppress cortisol synthesis makes them important tools in the medical management of Cushing's syndrome, particularly when surgery is delayed, unsuccessful, or not feasible. Ketoconazole was originally developed as an antifungal medication, but it also has an important role in the treatment of Cushing's syndrome. Over time, clinicians discovered that this drug can significantly reduce cortisol production, making it a valuable medical therapy for patients with hypercortisolism. Unlike some steroidogenesis inhibitors that target a single enzyme, ketoconazole acts more broadly. It inhibits several cytochrome P450 enzymes involved in adrenal steroid hormone synthesis. These include CYP11A1, CYP17, and CYP11B1, all of which play critical roles in the production of cortisol. Because multiple steps in the steroid pathway are blocked, cortisol production decreases substantially. This reduction can help improve many of the clinical manifestations of Cushing's syndrome, including hypertension, hyperglycemia, muscle weakness, and weight gain. One unique feature of ketoconazole is its effect on androgen production. Since it inhibits CYP17, an enzyme required for androgen synthesis, the drug lowers both cortisol and androgen levels. This differs from medications such as metyrapone, which may increase androgen precursor accumulation. For women with Cushing's syndrome, this dual action can be particularly beneficial. Lower androgen levels may help reduce symptoms such as acne, oily skin, and excessive hair growth. This makes ketoconazole an attractive option in selected patients. Because of its effectiveness and widespread availability, ketoconazole has often been used off-label as a first-line medical treatment for Cushing's syndrome, especially when surgery is delayed, contraindicated, or unsuccessful. However, ketoconazole is associated with several important safety concerns. The most serious is severe hepatotoxicity. In rare cases, liver injury can be life-threatening or even fatal. For this reason, liver function tests must be obtained before treatment begins and monitored regularly throughout therapy. Patients should also be educated about warning signs of liver injury. Symptoms such as fatigue, nausea, dark urine, jaundice, or abdominal pain should prompt immediate medical evaluation. Another major concern is QT interval prolongation. This electrical disturbance can increase the risk of potentially dangerous cardiac arrhythmias. The risk becomes even greater when ketoconazole is combined with other medications that affect cardiac conduction. Drug interactions are particularly important with ketoconazole. The medication is a potent inhibitor of the cytochrome 450 CYP3A4 enzyme, one of the body's most important drug metabolizing pathways. As a result, many medications may accumulate to higher than expected levels when taken together with ketoconazole. This increases the risk of adverse effects and toxicity from numerous commonly prescribed drugs. Careful medication review is therefore essential before initiating therapy. Despite these limitations, ketoconazole remains an important option in the medical management of Cushing's syndrome. Its ability to suppress both cortisol and androgen production makes it a useful tool when carefully prescribed and closely monitored. Successful treatment requires balancing its benefits against its potential risks, particularly liver toxicity, cardiac effects, and significant drug-drug interactions. Mitotane is one of the most unique drugs used in endocrinology. Unlike medications that simply block cortisol production, mitotane actually damages the adrenal cortex itself. Because of this powerful effect, it is classified as an adrenalytic agent. Interestingly, mitotane is chemically derived from DDT, a compound historically used as an insecticide. Although this origin may sound unusual, researchers discovered that the drug has a selective toxic effect on adrenal tissue. Mitotane primarily targets the zona fasciculata and zona reticularis, the regions of the adrenal cortex responsible for producing cortisol and adrenal androgens. As these cells are damaged and destroyed, hormone production gradually declines. The drug's most important clinical use is in the treatment of adrenocortical carcinoma, often abbreviated as ACC. This is a rare but aggressive cancer arising from the adrenal cortex. Because adrenocortical carcinoma frequently produces excessive steroid hormones, controlling hormone secretion is an important treatment goal. One of the most fascinating aspects of mitotane is its pharmacokinetics. The drug is highly lipophilic, meaning it has a strong attraction for fatty tissues. After administration, large amounts of the medication accumulate within adipose tissue throughout the body. This extensive storage creates a drug reservoir that slowly releases mitotane back into the circulation over time. As a result, the medication remains in the body far longer than most drugs used in clinical practice. The half-life of mitotane is remarkably prolonged and can range from approximately 18 days to as long as 159 days. Because of this, therapeutic drug concentrations may take weeks or even months to achieve. Clinicians must therefore be patient when initiating therapy and carefully monitor treatment response. The same property that allows long-term drug activity also presents challenges. Even after treatment is stopped, mitotane may continue to exert biological effects for an extended period because of ongoing release from adipose stores. As adrenal tissue is progressively destroyed, most patients eventually develop primary adrenal insufficiency. This outcome is often expected rather than accidental. Once sufficient adrenal damage has occurred, the body can no longer produce adequate cortisol and, in some cases, aldosterone. For this reason, patients treated with mitotane typically require lifelong hormone replacement therapy. Glucocorticoid replacement becomes essential, and some patients also require mineralocorticoid replacement to maintain normal fluid and electrolyte balance. Mitotane is also associated with significant adverse effects. Gastrointestinal toxicity is common and may include nausea, vomiting, diarrhea, abdominal discomfort, and loss of appetite. These symptoms can sometimes limit treatment adherence. Neurological side effects may also occur. Patients can experience dizziness, fatigue, impaired concentration, memory difficulties, or other manifestations of neurotoxicity, particularly at higher drug levels. Another critical concern is teratogenicity. Because mitotane can harm a developing fetus, effective contraception and careful pregnancy planning are essential during treatment. Although mitotane is a challenging medication to use, it remains a valuable therapy for adrenocortical carcinoma because of its unique ability to selectively destroy hormone-producing adrenal tissue. In some patients with Cushing syndrome, cortisol levels become dangerously high and require immediate intervention. This situation is known as critical hypercortisolemia and represents a true medical emergency. Waiting days or weeks for oral medications to work may not be an option. Severe hypercortisolemia can affect nearly every organ system. Patients may develop life-threatening infections, uncontrolled diabetes mellitus, severe hypertension, profound muscle weakness, acute psychosis, heart failure, or overwhelming metabolic disturbances. In these situations, cortisol levels must be lowered as quickly as possible. One of the fastest pharmacological tools available is etomidate. Although many clinicians recognize etomidate as an intravenous anesthetic agent, it also has a powerful endocrine effect when administered at lower doses. Etomidate belongs to the imidazole family of compounds and is chemically related to ketoconazole. Like ketoconazole, it interferes with steroid hormone production in the adrenal cortex. Its primary endocrine target is the enzyme 11-beta-hydroxylase, also known as CYP11B1. This enzyme catalyzes the final step in cortisol synthesis. By potently inhibiting this enzyme, Etomidate rapidly reduces cortisol production. An important advantage of etomidate is its speed of action. Cortisol levels can begin falling within hours, making it one of the most effective options for emergency cortisol control. Etomidate is particularly useful in patients with severe hypercortisolemia who are critically ill. Examples include patients with severe psychosis related to cortisol excess, those with overwhelming infections or sepsis, and individuals who require urgent surgery but need rapid hormonal stabilization beforehand. The medication is also valuable when oral therapy cannot be used. Patients who are vomiting, unconscious, mechanically ventilated, or otherwise unable to swallow medications may still receive effective treatment through intravenous administration. Because of its potency and potential risks, etomidate is typically administered as a continuous intravenous infusion in an intensive care unit. ICU monitoring allows clinicians to make frequent dose adjustments and respond quickly to any complications. One important concern is excessive sedation. At anesthetic doses, etomidate induces hypnosis and unconsciousness. Although lower doses are used for endocrine purposes, patients must still be monitored carefully for changes in mental status and level of consciousness. Another major challenge is avoiding overtreatment. If cortisol production is suppressed too aggressively, patients can develop iatrogenic adrenal insufficiency or even adrenal crisis. For this reason, cortisol levels are monitored closely throughout therapy. Many centers use a strategy known as block and replace. In this approach, etomidate is used to completely suppress excessive cortisol production, while carefully measured glucocorticoid replacement is administered separately. This allows clinicians to maintain precise control over hormone levels. Etomidate is not a long-term treatment for Cushing's syndrome. Instead, it serves as a rapid rescue therapy for critically ill patients. When every hour matters, its ability to quickly lower cortisol can be life-saving and provide a bridge to definitive treatment. Most medications used for Cushing's syndrome work by reducing cortisol production. Mifepristone takes a completely different approach. Instead of lowering cortisol levels, it prevents cortisol from exerting its effects on the body's tissues. Think of cortisol as a key and its receptor as a lock. In Cushing's syndrome, there is too much cortisol, and the hormone continuously activates its target tissues. Mifepristone works by blocking the lock, preventing cortisol from delivering its biological message. Mifepristone is a potent competitive antagonist at the glucocorticoid receptor. This means it competes directly with cortisol for receptor binding sites. Even when cortisol levels remain high, the hormone cannot effectively activate its target cells. The drug also blocks progesterone receptors. This additional action is clinically important and explains several of its unique therapeutic uses and adverse effects. Because mifepristone blocks cortisol action rather than cortisol production, the body responds differently than it does with other Cushing's medications. The adrenal glands continue producing cortisol, and hormone levels often rise even further because normal feedback mechanisms are disrupted. This creates a unique monitoring challenge. With most endocrine therapies, clinicians can follow blood or urine hormone levels to assess treatment response. With mifepristone, serum and urinary cortisol concentrations become unreliable markers because they remain elevated despite clinical improvement. Instead, treatment is guided entirely by the patient's symptoms and metabolic status. Physicians monitor parameters such as blood glucose levels, body weight, blood pressure, energy levels, and psychiatric symptoms to determine whether therapy is working effectively. One of the most important indications for mifepristone is Cushing's syndrome associated with type 2 diabetes mellitus or significant glucose intolerance. Excess cortisol promotes insulin resistance and increases glucose production by the liver, often causing difficult-to-control hyperglycemia. By blocking glucocorticoid receptor activity, mifepristone can significantly improve glucose metabolism. Many patients experience better glycemic control, making the drug particularly valuable when diabetes is a major clinical concern. However, treatment requires careful monitoring for adverse effects. One of the most serious complications is severe hyperkalemia. Elevated cortisol levels can still stimulate mineralocorticoid pathways, leading to excessive potassium loss. Low potassium levels can cause fatigue, muscle weakness, cramps, and potentially dangerous cardiac rhythm abnormalities. Because mifepristone also blocks progesterone receptors, women may develop endometrial thickening and abnormal uterine bleeding during prolonged therapy. These effects require ongoing clinical surveillance. Another critical safety consideration is pregnancy. Mifepristone has potent abortifacient properties because of its progesterone receptor antagonism. For this reason, it is contraindicated during pregnancy and is classified as pregnancy category X in traditional classification systems. Mifepristone occupies a unique place in the treatment of Cushing's syndrome. Rather than stopping cortisol production, it blocks cortisol's actions at the receptor level. This makes it especially useful for patients whose greatest challenge is cortisol-induced diabetes mellitus and metabolic dysfunction. Not all treatments for Cushing's syndrome target the adrenal glands. Some therapies work much earlier in the hormonal pathway by acting directly on the pituitary tumor that is driving excess cortisol production. One of the most important drugs in this category is pasireotide. Pasireotide is a second-generation somatostatin analog. It was specifically developed to target hormone-secreting pituitary tumors more effectively than older somatostatin-based medications. To understand how it works, remember that Cushing's disease is caused by a corticotroph pituitary adenoma. These tumor cells produce excessive amounts of adrenocorticotropic hormone, or ACTH. The elevated adrenocorticotropic hormone continuously stimulates the adrenal glands to produce excess cortisol. Many corticotroph adenomas express large numbers of somatostatin receptors on their surface. One receptor subtype is particularly important: somatostatin receptor subtype 5, or SSTR5. Pasireotide has a very high affinity for somatostatin receptor subtype 5. When the drug binds to these receptors, it suppresses adrenocorticotropic hormone secretion from the pituitary tumor cells. As adrenocorticotropic hormone levels fall, stimulation of the adrenal glands decreases, leading to a reduction in cortisol production. Because it targets the source of hormone excess, pasireotide is specifically indicated for Cushing's disease caused by a pituitary adenoma. It is not considered a primary treatment for adrenal tumors or ectopic adrenocorticotropic hormone-producing cancers. For many patients, lowering adrenocorticotropic hormone and cortisol levels can improve symptoms such as weight gain, hypertension, muscle weakness, skin changes, and metabolic abnormalities. In some cases, the medication can provide meaningful disease control when surgery is unsuccessful or not feasible. However, pasireotide is associated with one particularly important adverse effect: hyperglycemia. In fact, disturbances in glucose metabolism are among the most common challenges encountered during treatment. The reason lies in the drug's effects beyond the pituitary gland. Pasireotide not only suppresses adrenocorticotropic hormone secretion, but also inhibits insulin release from pancreatic beta cells. In addition, it reduces the secretion of important incretin hormones such as glucagon like peptide 1, or GLP-1, and glucose-dependent insulinotropic peptide, known as GIP. These hormones normally help regulate blood glucose after meals. When their activity is reduced, insulin secretion falls and blood sugar levels rise. As a result, some patients develop new-onset diabetes, while others experience worsening control of pre-existing diabetes. Blood glucose monitoring becomes an essential part of treatment. In clinical practice, a substantial proportion of patients receiving pasireotide require additional anti-diabetic therapy. Medications that enhance incretin pathways, such as dipeptidyl peptidase 4 inhibitors and glucagon-like peptide 1 receptor agonists, are often used to help counteract these metabolic effects. Pasireotide represents a targeted approach to treating Cushing's disease. By suppressing adrenocorticotropic hormone release at its source, it can reduce cortisol production and improve symptoms. However, successful treatment requires careful monitoring of blood glucose and proactive management of metabolic side effects. Let's revisit Mrs. Chebet, a 45-year-old woman with confirmed Cushing's disease caused by a pituitary adenoma. Her condition has progressed to the point where she has severe hypertension, significant hyperkalemia, and poorly controlled diabetes. Her blood pressure is dangerously elevated at 180/110 mm of mercury. Her potassium level is critically low, and her hemoglobin A1c is 10.5%, indicating prolonged and severe hyperglycemia. Although surgery is planned, her medical condition makes immediate anesthesia too risky. In situations like this, physicians often use bridging therapy. The goal is to stabilize the patient and reduce the complications of excess cortisol before definitive surgery is performed. For Mrs. Chebet, ketoconazole is selected as the medical treatment. While originally developed as an antifungal agent, ketoconazole also suppresses cortisol production by inhibiting several key enzymes involved in adrenal steroid synthesis. Because cortisol levels can decrease within days to weeks, ketoconazole provides a practical way to gain control of severe hypercortisolism before surgery. Lower cortisol levels can lead to significant improvements in cardiovascular and metabolic health. As cortisol production declines, blood pressure often becomes easier to control. Excess sodium and water retention decrease, helping reduce the burden on the cardiovascular system. This is particularly important in patients with severe hypertension who face increased surgical risk. Improved cortisol control can also enhance glucose regulation. Since cortisol promotes insulin resistance and excessive glucose production by the liver, reducing cortisol levels often leads to better glycemic control. This helps lower the risk of perioperative complications. However, ketoconazole therapy requires careful monitoring. One of the most important concerns is hepatotoxicity. Although uncommon, liver injury can be severe and occasionally life-threatening. Before treatment begins, baseline liver function tests are obtained. These typically include AST, ALT, and bilirubin levels. Once therapy is started, liver function should be reassessed regularly, often on a weekly basis during the initial treatment period. Another important consideration is the possibility of adrenal insufficiency. If cortisol production is suppressed too aggressively, patients may develop symptoms such as fatigue, dizziness, nausea, weakness, or low blood pressure. Clinical monitoring is essential to ensure cortisol levels are reduced safely. Mrs. Chebet's severe hyperkalemia also requires active management. Excess cortisol can stimulate mineralocorticoid pathways, causing excessive potassium loss through the kidneys. This contributes to muscle weakness and increases the risk of cardiac arrhythmias. To correct the potassium deficit, supplementation is often required. In addition, spironolactone may be prescribed. This medication blocks mineralocorticoid receptor activity, helping conserve potassium while also assisting with blood pressure control. Over the following weeks, the goal is to improve blood pressure, normalize potassium levels, and achieve better glucose control. By reducing the effects of excess cortisol, ketoconazole helps transform a high-risk surgical candidate into a safer candidate for definitive pituitary surgery. This case highlights the important role of pharmacological bridging therapy in the modern management of severe Cushing's disease. Let's follow up on Mr. Johnson, a 32-year-old man with primary adrenal insufficiency. He has been taking hydrocortisone replacement therapy and initially showed significant improvement. His current regimen consists of 15 mg in the morning and 5 mg in the afternoon, providing a total daily dose of 20 mg. Despite treatment, he returns to the clinic with persistent symptoms. He reports feeling dizzy whenever he stands up. He also continues to experience strong salt cravings. These complaints suggest that something is still missing from his hormone replacement plan. At first glance, it might be tempting to increase his hydrocortisone dose. However, a closer look at his clinical findings tells a different story. His blood pressure is low while sitting and falls even further when he stands. This marked drop in blood pressure is known as orthostatic hypotension. It indicates inadequate maintenance of blood volume and vascular tone. His laboratory results provide additional clues. His sodium level is low at 131 milliequivalents per liter, while his potassium level is elevated at 5.4 milliequivalents per liter. This combination of hyponatremia and hyperkalemia is highly suggestive of aldosterone deficiency. Remember, primary adrenal insufficiency affects the entire adrenal cortex. Patients lose not only cortisol production but also aldosterone production. Hydrocortisone effectively replaces cortisol, but it may not provide enough mineralocorticoid activity to fully replace aldosterone. The persistent salt craving, low blood pressure, low sodium, and high potassium all point toward inadequate mineralocorticoid replacement rather than insufficient glucocorticoid therapy. The pharmacological diagnosis is therefore incomplete aldosterone replacement. To address this problem, fludrocortisone should be initiated. A common starting dose is 0.1 mg taken orally once daily. Fludrocortisone acts like aldosterone, helping the kidneys retain sodium and water while increasing potassium excretion. As sodium and water retention improve, blood volume gradually expands. Blood pressure rises toward normal levels, and symptoms of orthostatic dizziness begin to resolve. Patients often notice a reduction in salt cravings as electrolyte balance is restored. Importantly, his current hydrocortisone regimen should be maintained. His symptoms and laboratory findings do not suggest cortisol deficiency. Instead, they indicate a specific need for additional mineralocorticoid support. Follow-up is essential after starting fludrocortisone. Clinicians will monitor blood pressure to ensure orthostatic hypotension improves. Repeat laboratory testing will assess whether sodium levels normalize and potassium levels return to the normal range. Another valuable monitoring tool is plasma renin activity. In adequately treated patients, Renin activity is generally maintained within the upper half of the normal range. Persistently elevated renin may indicate the need for additional fludrocortisone. This case highlights an important principle in primary adrenal insufficiency. Successful treatment requires replacement of both cortisol and aldosterone. Correcting only one hormone deficiency may leave patients with ongoing symptoms and prevent full clinical recovery. Let's examine a classic example of iatrogenic adrenal insufficiency and why corticosteroids should never be stopped abruptly after long-term use. A 60-year-old man has been taking high-dose prednisone, 40 mg daily, for 6 months to control rheumatoid arthritis. The medication successfully reduced inflammation and improved his joint symptoms. However, he began experiencing significant gastrointestinal discomfort and decided to stop the medication on his own. At first, nothing seemed unusual, but within 48 hours, he developed severe nausea, profound weakness, and overwhelming fatigue. He became dizzy and struggled to stand upright. Family members noticed he appeared pale and increasingly unwell. When he arrived at the emergency department, his blood pressure was dangerously low at 85/50 mm of mercury. Laboratory testing revealed hypoglycemia. His symptoms were consistent with an adrenal crisis, a life-threatening endocrine emergency. To understand what happened, we need to look at the hypothalamic-Pituitary-Adrenal, or HPA, axis. Under normal conditions, the hypothalamus releases corticotropin-releasing hormone, which stimulates the pituitary gland to produce adrenocorticotropic hormone. Adrenocorticotropic hormone then signals the adrenal glands to produce cortisol. Prednisone acts like cortisol in the body. When taken for prolonged periods, the brain senses an abundance of glucocorticoid activity. As a result, corticotropin-releasing hormone and adrenocorticotropic hormone production are progressively suppressed through negative feedback. Over months of continuous therapy, the adrenal glands receive very little adrenocorticotropic hormone stimulation. The zona fasciculata, the region responsible for cortisol production, gradually shrinks and becomes atrophic. This means the adrenal glands lose much of their ability to produce cortisol independently. While the patient is taking prednisone, this suppression is usually not noticeable because the medication provides the glucocorticoid activity the body needs. The problem arises when the drug is stopped suddenly. Because the adrenal glands have become dormant, they cannot immediately resume cortisol production. The body suddenly loses its glucocorticoid supply, creating a state of acute cortisol deficiency. This condition is known as secondary adrenal crisis because the problem originates from suppression of the hypothalamus and pituitary rather than direct adrenal disease. Management must begin immediately. The first priority is aggressive intravenous fluid resuscitation to restore blood pressure and circulating volume. At the same time, stress-dose intravenous hydrocortisone is administered to rapidly replace the missing cortisol. Most patients improve dramatically once fluids and glucocorticoids are provided. Blood pressure stabilizes, blood glucose levels normalize, and symptoms begin to resolve. After recovery, the patient should never return home without a carefully structured tapering plan. Rather than stopping prednisone abruptly, the dose must be reduced gradually over time. A common approach involves decreasing the dose by approximately 10 to 20% every 1 to 2 weeks, allowing the hypothalamic-Pituitary-Adrenal axis to recover slowly. This case highlights a critical clinical lesson. Long-term corticosteroids can suppress the body's natural cortisol production. Abrupt withdrawal can trigger a potentially fatal adrenal crisis, making gradual tapering an essential part of safe therapy. Let's test our understanding of adrenal pharmacology with 3 important clinical questions. These concepts frequently appear in examinations and are highly relevant in real-world patient care. Question 1 asks, which medication treats Cushing's syndrome by acting as a competitive antagonist at the glucocorticoid receptor? The correct answer is mifepristone. Unlike most drugs used for Cushing's syndrome, mifepristone does not reduce cortisol production. Instead, it blocks cortisol from binding to its glucocorticoid receptors. Think of it as placing a cover over the receptor so cortisol cannot exert its effects. This unique mechanism makes mifepristone especially useful in patients with Cushing's syndrome who also have severe hyperglycemia or type 2 diabetes mellitus. Even though cortisol levels remain elevated, its biological actions are greatly reduced. Question 2 asks, what replacement therapy is required in Addison's disease, but is often unnecessary in secondary adrenal insufficiency? The correct answer is mineralocorticoid replacement. Patients with Addison's disease have primary adrenal insufficiency. The adrenal cortex is damaged, resulting in deficiencies of both cortisol and aldosterone. Because aldosterone production is lost, these patients require fludrocortisone replacement. In contrast, patients with secondary adrenal insufficiency usually have a pituitary or hypothalamic problem. Their aldosterone production remains largely intact because it is controlled mainly by the renin-angiotensin-aldosterone system rather than adrenocorticotropic hormone. This distinction is clinically important. Both conditions require glucocorticoid replacement, but only primary adrenal insufficiency routinely requires mineralocorticoid therapy. Now for question 3. Which drug blocks CYP11B1, also known as 11-beta-hydroxylase, and frequently causes hirsutism and acne in women due to precursor shunting? The correct answer is osilodrostat or metyrapone. These medications inhibit the final enzymatic step in cortisol synthesis. Specifically, they block the conversion of 11-deoxycortisol into cortisol by inhibiting 11-beta-hydroxylase. When cortisol synthesis is interrupted, precursor molecules accumulate. Instead of becoming cortisol, many of these precursors are diverted into androgen synthesis pathways. This process is known as precursor shunting. As androgen levels increase, women may develop hirsutism, which refers to excessive facial or body hair growth. Acne can also become more prominent because of increased androgen activity. These drugs may additionally increase levels of mineralocorticoid precursors, contributing to hypertension, fluid retention, and hyperkalemia. So let's summarize the key points. Mifepristone works by blocking the glucocorticoid receptor. Primary adrenal insufficiency requires mineralocorticoid replacement with fludrocortisone. And metyrapone and osilodrostat inhibit CYP11B1, leading to reduced cortisol production and potential androgen-related side effects. Understanding these mechanisms makes it much easier to predict both the therapeutic effects and adverse effects of these important endocrine medications. Let's continue our clinical knowledge check with 2 high-yield questions on Cushing's syndrome and adrenal emergencies. Question 4 asks, which drug used in the medical management of Cushing's syndrome carries a black box warning for severe, potentially fatal hepatotoxicity? The correct answer is ketoconazole. Ketoconazole is an imidazole antifungal that is widely used off-label to reduce cortisol production. It works by inhibiting multiple cytochrome P450 enzymes in the adrenal steroid synthesis pathway. This includes key steps required for cortisol and androgen production. Because it interferes with hepatic cytochrome P450 systems, Ketoconazole can also cause direct liver toxicity. In rare cases, this hepatotoxicity can be severe and even fatal. This is why it carries a black box warning. Patients must have baseline liver function tests before starting therapy. AST, ALT, and bilirubin must be monitored regularly during treatment. Any signs of liver injury require immediate discontinuation. Clinically, ketoconazole remains useful, but only with careful risk-benefit assessment and close monitoring. Now let's move to question 5. A patient arrives in the emergency department in full adrenal crisis. They are in shock, confused, and severely hypoglycemic. What is the most appropriate immediate pharmacological intervention? The correct answer is IV hydrocortisone. Adrenal crisis is a life-threatening endocrine emergency caused by acute cortisol deficiency. It may be triggered by infection, trauma, surgery, or abrupt steroid withdrawal. The key issue is failure of the body to mount a stress cortisol response. This leads to severe hypotension, vascular collapse, and metabolic instability. Immediate treatment must never be delayed. The first-line drug is intravenous hydrocortisone. A typical emergency dose is 100 mg IV as a bolus, followed by 50 mg every 6 hours or continuous infusion. Hydrocortisone is preferred because it replaces both glucocorticoid and partial mineralocorticoid activity during acute stress. It rapidly restores vascular tone, improves blood pressure, and corrects hypoglycemia. In addition to steroids, aggressive IV fluid resuscitation with isotonic saline is essential. Dextrose may be added if hypoglycemia is present, but pharmacologically, hydrocortisone is the cornerstone. Other options in the question highlight important distractors. Oral prednisone is inappropriate because the patient is critically ill and cannot reliably absorb oral medication. Fludrocortisone is not used in the acute phase of adrenal crisis because high-dose hydrocortisone already provides sufficient mineralocorticoid effect. Pasireotide is unrelated to adrenal crisis and is used for Cushing's disease by suppressing adrenocorticotropic hormone from pituitary tumors. So the key takeaway is simple. Ketoconazole carries a serious hepatotoxicity warning and requires liver monitoring. And in adrenal crisis, the life-saving first step is immediate IV hydrocortisone plus fluid resuscitation. Fast recognition and correct drug choice can make the difference between recovery and fatal outcome in endocrine emergencies. Let's bring everything together into a clear clinical summary of adrenal disorders and their pharmacological management. Adrenal insufficiency is fundamentally a state of hormone deficiency. The goal of treatment is simple but precise. Replace what the body can no longer produce. Glucocorticoid replacement is the cornerstone. Hydrocortisone is the preferred drug because it closely mimics natural cortisol. In healthy physiology, cortisol follows a diurnal rhythm, peaking in the early morning and declining throughout the day. Hydrocortisone dosing is designed to replicate this natural pattern as closely as possible. But treatment does not stop with cortisol replacement. In primary adrenal insufficiency, the adrenal cortex also fails to produce aldosterone. This requires mineralocorticoid replacement with fludrocortisone. Together, these therapies restore both stress response and fluid electrolyte balance. Another critical principle is stress dosing. During illness, surgery, or trauma, the body normally increases cortisol output. Patients with adrenal insufficiency cannot do this. So hydrocortisone doses must be increased during stress to prevent adrenal crisis. This is a life-saving concept. Now contrast this with Cushing's syndrome. Here, The problem is the opposite. There is too much cortisol, not too little. The first-line treatment is usually surgical removal of the source of excess hormone. This may involve pituitary surgery, adrenalectomy, or removal of an ectopic adrenocorticotropic hormone-producing tumor. However, surgery is not always immediately possible. That is where pharmacological therapy becomes essential. Medications can bridge patients to surgery, control severe symptoms, or manage persistent disease after surgery. These drugs act at different points in the cortisol pathway. Steroidogenesis inhibitors reduce cortisol synthesis directly. Drugs like ketoconazole and metyrapone block key adrenal enzymes, lowering cortisol production. Adrenoliptic agents like mitotane go further. They damage adrenal cortex cells themselves, leading to long-term reduction in hormone output. Glucocorticoid receptor antagonists such as mifepristone take a different approach. They do not lower cortisol levels. Instead, they block cortisol from acting at its receptor. Finally, pituitary-directed therapies like pasireotide reduce adrenocorticotropic hormone secretion from corticotroph tumors. This lowers adrenal stimulation at its source. Each drug targets a different level of the hypothalamic-pituitary-adrenal axis. Some reduce synthesis, some destroy tissue, some block receptors, and others suppress hormone signaling upstream. The key clinical insight is this: adrenal insufficiency is about replacement. Cushing's syndrome is about suppression. And every drug choice depends on understanding exactly where in the hormonal pathway the problem begins.